So YouTube live you have started?
Yes, sir.
So shall I start?
Yes, sir. Start, sir.
Okay. So good evening and good evening all of you. Welcome to Dr. M.S. Biradar Memorial Lectures in Medicine. It's my great privilege to say thanks to all the speakers, the 4 distinguished speakers from the 4 continents are involved here. And there are 4 countries and 3 continents the speakers belong to. Professor Paulo Pelosi, the first speaker, a legendary professor of anesthesiology from University of Genoa. The second speaker is Professor František Kolar, a great developmental cardiologist from Czech Academy of Sciences. Third speaker, Professor of Neurological Surgery, John Marino Ramirez from University of Washington. And the fourth speaker, Professor Gustavo Zubieta Calleja from a renowned professor of pulmonologist and director of IPPA from La Paz, Bolivia. Today's program, the chief guest and the inaugurator, Professor R.S. Mudhol, Honorable Vice Chancellor in charge of the BLD University, from BLD University site as a host, and inauguration will be also done from the La Paz, Bolivia, by Dr. Gustavo Zubieta on behalf of the IPPA Bolivia, because it's a jointly hosted program along with the BLD University. IPPA La Paz is jointly hosting this conference. Today's program, apart from the chief guest, Professor R.S. Mudhol, the entire program will be presided over by Professor Dr. Arvind V. Patil, Dean of Faculty of Medicine, BLD deemed to be University. There are all distinguished speakers are here. Chairperson of the sessions are already here. I welcome all the chairperson along with the speakers. I welcome the chief guest, president of the function, distinguished professors and faculty members. Here I am finding some of the distinguished professors like Professor Dr. A.M. Ramesh from KSTA, Government of Karnataka, and some other professors are already joined. So without delaying that time, I will first inform the program today that to all the participants and the guests, that first program will be the introduction to chief guest and president by Dr. Lata Mullur, professor of physiology. It will be followed by inauguration of the program. Inauguration is the 2 steps. First step from the BLD, a click of button by Dr. R.S. Mudhol will immediately open. From Indian side, the inauguration of Dr. M.S. Biradar Memorial Lecture. A great physician. We have lost him last month due to COVID pandemic. He was also professor of medicine, our mentor, a great visionary leader. So it's a fitting tribute by the world-renowned clinicians to speak on sciences whom Dr. M.S. Biradar as a person loved like anything. And except Professor Paulo, all the 3 speakers here are personally known to Dr. M.S. Biradar. That's one great part of this program itself. So after inauguration of Dr. R.S. Mudhol sir from the Vice Chancellor, BLD University, next it will be second slide will be open, and that will be inaugurated by Dr. Gustavo Zubieta. And immediately after that, program will be continued as is scheduled, which I will monitor. So I first request now Dr. Lata Mullur to introduce chief guest and president of the today's function. Over to Dr. Lata Mullur, professor of physiology and IQSU director.
Thank you, Dr. Kushal Das sir. Namaste and hello to all distinguished speakers and the delegates, the participants from various countries and also India. So today I am privileged to introduce our Honorable Vice Chancellor sir, Professor R.S. Mudhol, who has very recently joined our institution. Sir is professor in ENT and worked in various capacities as professor and head, medical superintendent, vice principal, and dean faculty of medicine at his previous institutes before joining our institution. Sir has completed his MBBS and MS in ENT from Karnataka Medical College, Hubballi, Karnataka, And sir has also pursued his MBA in hospital management from Annamalai University. And sir is held various academic and administrative positions in Kahir and contributed immensely in establishment of various new programs and laboratories and other events at his previous institution. Sir is also was a part of various national and international activities like conferences, CMEs. He was part of it. He has organized also, and he has visited many countries for academic purposes. Apart from being administrator, Sir is a researcher and a good teacher. He has numerous papers, chapters, book chapters, and book publications in his credit, which are published in national and international journals. And being a good teacher, he is a recipient of Teachers of Teacher Award and Best Teacher Award. Sir, being a very good old friend of late Professor M.S. Biradar, sir, is going to continue the legacy in BLD University. Present Professor R.S. Mudol, sir, to the.
Hello. Dr. Lata, you are not audible.
Hello, sir.
Yeah, please continue.
Hello.
Yes, yes, we are hearing.
Hello.
Yeah, we are hearing.
Sir, am I audible?
Yes, you are audible.
Sir.
Quickly.
Sir, shall I repeat, sir? Sir, shall I continue or like?
No,
was I audible or interrupted in between?
In between, interrupted. Last part.
Okay.
Last sentence.
Okay, sir. Sir, being a very good dynamic administrator and academician, he is a recipient of Best Teacher Award and Teacher of Teacher Award in his previous institution. Sir, being a very good old friend of Professor late M.S. Biradar, sir, he is going to continue the legacy of BLD University as a Vice Chancellor. Here I present Professor M.S. Mudol, sir, to the audience.
R.S. Mudol, sir.
Sorry, R.S. Mudol, sir.
Thank you very much. Thank you, Lata.
Thank you, Dr. Lata.
My pleasure. My pleasure.
I also request you to introduce our today's president of the function, Dr. Arvind V. Patil, Dean of Faculty of Medicine.
Thank you, sir. Dr. Arvind V. Patil, Principal of Shri B.M. Patil Medical College Hospital and Research Center, and holding the position of Dean, Faculty of Medicine of BLD, deemed to be university. And he is a professor of surgery in the medical college. A bright young boy from Sainik School, opted for medicine as his career and passed out successfully his MBBS degree from Karnataka Medical College, Hubballi in Karnataka. Further, he opted for surgery as his specialty in his post-graduation and completed MS in General Surgery from JN Medical College, Belgavi, Karnataka. He started his career as a faculty in Shri B.M. Patil Medical College and became professor in surgery. His skills and deep knowledge in surgery made him immensely popular among colleagues and students. He is the architect of progress and development of super specialty wing in the teaching hospital of BLD deemed to be university. As a head of medical college, Sir infuses dynamism, innovation, novelty, bold and courageous steps to make the medical college as one of the distinctly unique and quality medical institution in India. He created some important roadmaps along with late Professor M.S. Biradar, Honorable Vice Chancellor BLD deemed to be university, by promoting more scientific temperament with research, innovation, and IT-enabled teaching, patient care, and hospital infrastructure development under the university. These made BLD University to further extend new faculty named Faculty of Allied Health Sciences. The new faculty pushes multidisciplinary teaching in health sciences along with interdisciplinary research and collaborations. Dr. Arvind Patil is not only a vibrant medical administrator or professor of surgery, but also an activist of nature and environment. His involvement in afforestation in this arid part of North Karnataka as Koti Vrikshathana Abhiyana, which means the plan of planting 1 crore saplings under the leadership of Honorable Chancellor Dr. M.B. Patil is truly praiseworthy. He has numerous publications and book chapters in his credit. Further, he has been honored with several awards for his contribution to medical science and social services. With this brief introductory note, here I present our Dean Faculty of Medicine of BLD University, Dr. Arvind Patil, sir.
Thank you, Lata. Thank you, sir.
Thank you, sir. My pleasure. Thank you.
So thank you very much, Dr. Lata, for introduction to our today's chief guest and presiding of the functions. And
my pleasure.
Before we start now inaugural program, and I like to say that this entire program has been blessed and best wishes by our Honorable Chancellor, Dr. M.B. Patil, sir, in his message in the morning to me. So thank you, our great visionary leader, Dr. M.B. Patil, sir, Chancellor of the University. Now I request Honorable Vice Chancellor to inaugurate today's program on behalf of the BLD deemed to be University. Anand. Yeah. I request Dr. R.S. Mudhol. So thank you very much, sir, Honorable Vice Chancellor, sir, for inauguration on behalf of the BLD deemed to be University for today's program. Now I request Professor Gustavo Zubieta. It is the virtual inauguration of today's program from your institution, High Altitude Pulmonary Pathology and Pulmonary and Pathology Institute, La Paz. Professor Gustavo.
Thank you very much, Professor Kushal Das. Dear Professor Mudal, Vice Chancellor, and Dr. Patil, whom I have personally met when I was at VLD, I feel extremely honored to be participating here, thanks to the initiative of Professor Kushal Das, because he is the mastermind behind the ideas in these activities. And I think Professor Biradar could not have a greater honor than to have a memorial lecture be given periodically in his name. He was a great man, without doubt. And we at High Altitude had the honor of having him during our 7th Chronic Hypoxia Symposium here in La Paz, Bolivia. It was a wonderful event. He was a fantastic philosopher, a great physician, a great human being who practically gave his life for his patients and his students at BLDE. We honor him greatly, and the High Altitude Pulmonary and Pathology Institute team is very delighted to be part of this event. Thank you very much, Professor Kushal Das.
Yeah, please.
I want to also say that I would like to say hello to Professor Venkatesh, who is the man that has brought me also to BLDE.
Yes, thank you. This is the inauguration from La Paz, Bolivia, on behalf of the High Altitude Pulmonary and Pathology Institute.
Very beautiful.
Thank you very much. Thank you. So the virtual inauguration program is over. I will now request Honorable Vice Chancellor Dr. R.S. Mudhol, sir, to say a few words as a chief guest of today's function. After that, immediately the program of scientific program will start. Over to Professor R.S. Mudhol, sir, Honorable Vice Chancellor, sir.
Good evening to all. Dear friends, it is indeed honor to all of you to this very important event, Dr. M.S. Biradar Memorial Guest Lecture in Medicine. On behalf of the BLD University, and on behalf of the Chancellor Sri M.B. Patil, and on my own behalf, I bring greetings to everyone who have joined this program. I welcome all the eminent scientists and researchers for this program. I welcome Professor Paulo from Italy, Pelosi from Italy, Professor František Kolar from Czech Republic, Professor Jan Marian Ramirez from USA, Professor Gustavo Zubieta from Bolivia, and I also welcome Dr. Arvind Patil, Dean and Principal of the Medical College, all the faculty members, researchers of BLD universities, Sri B.M. Patil Medical College, Hospital and Research Center, Vijaypura. I really appreciate the efforts of Professor Das for arranging such a memorable academic event in the memory of great visionary leader, Professor M.S. Biradar, who had a dream of arranging the research collaboration with the eminent research centers and institutes of the Western globe. It is indeed a very befitting memorial event to Professor M.S. Biradar, who has always strived hard to bring the international research and academic collaboration to the BLD University Vijaypura. Dr. M.S. Biradar, Memorial Guest Lecture in Medicine, is a very aptly done by Professor Kushal Das, as it is a dream of Dr. M.S. Biradar to start Advanced Medical Research Center at BLD University and collaborate with Bolivia University to do the combined collaborative research in the advanced medical field. And he himself visited Bolivia, a very high altitude place where hypoxia is a problem. Dr. Biradar with Professor Das visited the place and met the Professor Gustavo and other researchers there and made a collaboration in 2017. Professor Gustavo and Professor Jan Marian Ramirez visited BLD University for International Symposium in 2019 and interacted with all faculty members and researchers of BLD University. This is one step to realize the dreams of our great leader, Dr. M.S. Biradar, who has traveled across the globe and had a lot of ideas to collaborate BLD University with world's top institutes. I thank Professor Das for arranging such a wonderful event towards his idea. This is the event is the best tribute to late Professor M.S. Biradar. Thank you very much. On behalf of the university, I wish this program a great success, and all the resource persons, I thank, they have joined from all over the globe. All professors, thank you very much to joining the memorial lecture of Professor M.S. Biradar to realize his ideas of combined research collaborations with our Advanced Medical Research Center at BLD University. Once again, I thank you on behalf of my university for everybody who has joined online this program. Thank you one and all.
Thank you very much. Thank you very much, Honorable Vice Chancellor, sir, and Chief Guest of today's function. And now the time has come, with the permission of the President of today's function, Professor Arvind Patil. I need a permission from you. Can we start the program now?
Sir, please go ahead, sir.
Okay, thank you very much, President. And now the first program will be starting. So first speaker is Professor Paulo Pelosi, who will be introduced by the chairperson of the session, Dr. Vidya A. Patil. Dr. Vidya A. Patil, the professor and head of the Department of Anesthesiology, B.M. Patil Medical College, BLD University. She did her MBBS and MD in anesthesia from JN Medical College, Belgaum. Her research interest is Actually, obstetrics and pediatric anesthesia, and academic interest is teaching and learning skills. She's also a medical education coordinator for MER. So over to Dr. Vidya Patil to introduce today's first speaker, Professor Paulo Pelosi, a legendary anesthesiologist from Genoa. Dr. Vidya Patil.
Yes, sir. A very good evening, everyone gathered here on the virtual platform. At the very outset, I would like to immensely thank Professor Kusal Das for the opportunity given to me to chair this wonderful session. Coming to the awe-inspiring, stupendous introduction of Paulo Pelosi, sir, our first speaker. Paulo Pelosi, sir, is currently the professor and director in anesthesia and intensive care at Genoa University, Italy. Professor Paulo Pelosi grew up in Milan and attended University of Milan, graduating magna cum laude in medicine and surgery. He completed his studies first as specialist in anesthesia and intensive care, and then as research fellow in anesthesiology at the University of Milan. He served as associate professor in anesthesia and intensive care medicine at the University of Insubria, where he is from 1999 to 2010. He is currently chief professor in anesthesia and intensive care and director of the specialty school in anesthesiology at the University of Genoa, as well as head of the anesthesia and intensive care unit at the IRCCS San Martino IST Hospital, Genoa, Italy. His activity has always been directed both to the clinical and research field. The main research interests of Pelosi, sir, have been directed to respiratory physiology during anesthesia and respiratory failure. Professor Pelosi developed several collaborations with highly scientifically reputed groups in European and extra-European countries for research in the field of mechanical ventilation and sepsis in experimental and clinical settings. In this line, he promoted the constitution, the ProveNet Investigators Group, a large network of researchers worldwide focusing on protective ventilation and its effects on main outcome measures, and organizing large-scale databases, observational trials, and randomized controlled trials worldwide. Furthermore, he is also experienced in meta-analysis and leading of large prospective randomized controlled trials, as well as observational trials. He served as president of the European Society of Anesthesiology from 2010 to 2011, and first as secretary and then as head of the Respiratory Intensive Care Assembly 2 at the European Respiratory Society. He is actually member of the council at the World Federation of Societies of Intensive Care and Critical Care Medicine. He is member of several boards of international meetings, organizing committees. He was also editor and co-editor of several books and scientific issues. He is author and co-author of 399 original papers, 143 papers under invitation, 170 book chapters he has written. He has written 72 proceedings, 264 presentations are also to his credit at meetings, and 400 medical and scientific peer review papers are also to his credit, and he has lectured in more than 1,387 national and international meetings on ventilation management during the perioperative period and on the pathophysiology and treatments of acute respiratory failure. I consider myself to be very much privileged and fortunate for having had this opportunity of introducing such a great personality. Thank you for the opportunity, sir. May I now go to Dr. Pelosi, sir.
Thank you very much for this very kind introduction. Almost all my CV full, even better than I have in my records. So thank you very much. So it's a great privilege really to be here and present relatively old data on COVID that we previously presented, and very new data. And I'm really grateful to Professor Kushal Das for organization, and of course Professor Gustavo Zubeta, with which was really, I read before, inspiration, no? Inspiring generation, and was just during a meeting like that we met together, and it was a very inspiring meeting to understand better COVID-19, or at least to give new interpretation on COVID-19. So there are no conflict of interest for this lecture, and this is the results anyway of a multidisciplinary team research in the Policlinical Hospital in San Martino, Genoa, with multidisciplinary activities with infectivologists, pneumologists, anatomopathologist, and of course, anesthesiologists and intensive care physicians. There's a large collaboration with radiologists, physiologists, and especially colleagues from the United States who supported us in new analysis for the blood perfusion that I will show you. So this is the light and the dark side of the moon. Yes, because we are used to analyze and to interpret, especially respiratory failure, by looking at the aeration, and especially mainly by CT scan. The dark side of the moon is perfusion. And we all know, and especially Gustavo, who is a real physiologist, there is a balance between aeration and perfusion to determine gas exchange. And I will try to show you how much the investigation on perfusion, that for us was completely new, was important to understand better gas exchange in COVID-19, and was important to individualize therapeutic management. And I think personally changed my view of the interpretation of gas exchange in respiratory failure. And I think that these techniques will be used in the next future in the so-called traditional RDS, if we'll see any more, because I can tell you that since COVID, we did not observe anymore any case of traditional RDS in the ICU. Anyway, just to be back on the VIQ mismatch, dead space, and shunt. This is a relatively easy graphics showing that we have areas of the lung aerated and perfused, in which the ventilation perfusion ratio is around 1. Then we have areas of the lung in which we have no ventilation with perfusion, and these are areas with VIQ ratio equal to 0, which means what we call shunt, and areas of the lung in which we have ventilation but not perfusion, and these are the typical areas for the dead space. Overall, we have a distribution of the VIQ ratio from the normal VIQ ratio to the lower VIQ ratio or high VIQ ratio, and the two extremes with the shunt, so non-aerated areas perfused, and the dead space with ventilation not perfused. The shunt plus the low VIQ areas is so-called venous admixture. The low VIQ areas plus the dead space is called wasted ventilation. This is just an example. If you have a patient with normal alveoli and normal perfusion with a FiO2 of 50% and normal hemoglobin and respiratory quotient. If we have area with low VIQ ratio, so areas in which we have less ventilation, these areas are characterized by a reduction in the oxygenation and an increase in the PCO2. On the other side, if you have areas completely not ventilated but perfused, all the blood from the venous side is diverted in the arterial side, and this is the true shunt. And this is the mixture, the venous admixture due to the hypoxia and increasing PCO2 due to the low VAQ areas and the true shunt. On the other side, we can have high VAQ ratio, which have more ventilation, or a reduction in perfusion, as shown here, like microthrombosis, in which we have a maintenance of oxygenation, but a major decrease in the PCO2. And on the other side, if we have areas with no perfusion, we will continue to ventilate the alveoli without any effect, because these areas are not ventilated. So the areas with low VAQ and dead space are so-called wasted ventilation, with high VAQ areas and dead space. So this is a schematic representation on how is the relationship between ventilated areas or aerated areas from non-dependent to the dependent lung region in the so-called traditional RDS. And you see the non-dependent part of the lung in supine position are mainly characterized by high VAQ areas, so more ventilation than perfusion. The middle part of the lung characterized by low VAQ areas, and the lower part of the lung characterized by non-aerated lung, collapsed or consolidated, but perfused. And different causes of alteration in regional perfusion may be detected. So hypoxic vasoconstriction, swelling of the endothelial cells, microthrombosis or regional perfusion obstruction, and collapse, mainly in the most dependent part of the lung. Hypoxic vasoconstriction, airway pressure, and positioning may deeply affect regional perfusion. This is the typical perfusion in the traditional RDS. You see here in red more perfusion, in blue less perfusion, and in most of cases in traditional RDS, perfusion is gravitational dependent, more in the dependent part of the lung where we have non-aerated lung. And so in traditional RDS, we have more atelectasis and less alveolar consolidation in the dependent part of the lung, so non-aerated lung, with a gravitational distribution of regional perfusion. So hypoxia in traditional RDS is mainly due to the true shunt. What we try to understand more about COVID-19, and this is a study that we performed by using cryobiopsy. So we used a technique to monitor the evolution of cancer and diagnosis of cancer by different samples in the lung by fibroscope. And we performed these samples just 20 minutes after death and during mechanical ventilation. So very fresh samples, completely different from conventional and traditional autoptic studies. We found that these patients, they died around 25 days. So of course, there was a long period of mechanical ventilation. And we were able to match anatomical data with CT scan. And we identified the so-called early death pattern. You see here open alveoli with alteration of the epithelial cells, alveolar cells in the black arrows, and the hyaline membrane in pink areas. In the areas of the CT, some aeration. Then a so-called mid-dead pattern in the gray ground glass areas that you can see here, a complete alteration of the alveolar and capillary structure with initial areas of fibrosis. Not much microthrombosis as we expected, but we used a lot of a very specific anticoagulation protocol. Then we have the white areas. You see a complete disorganization in terms of the lung. You don't recognize anything more. And the so-called late DAD honeycombing in the peripheral area of the lung, where we found areas of so-called infiltration in the alveoli with mucosinosis, not edema, and a complete disorganization in the interstitium. And you can see here in the block D, in which you can see the long cells are smooth muscle cells, which demonstrate a complete disorganization. And Professor Gustavo Zubieta proposed, and we are preparing a paper on that, that this complete alteration in the lung may be defined as pneumolysis. And so we can combine pneumolysis and vascular lysis together with cell infiltration and alveolar mucosinosis with fibrosis in the mid and late DAD pattern. So not much edema. This is the big difference in our opinion as compared to RDS. There is no more edema, there is more consolidation and infiltration. This is another study which has been recently accepted and is being published soon on a top journal in physiology, in which we performed an analysis of collagen from the samples. You see low or high amount of collagen, which is associated with the amount of air spaces. Just to be short, when we correlated a radiographic score at the CT and the amount of collagen, you can see here that if the score was low, it was very likely that the amount of collagen was negligible. But when the score was high, so when we have an altered pattern at the chest, at the CT scan, you see that we have patients in which they developed collagen and patients without collagen. So this means that the CT scan per se does not identify fibrosis in COVID-19. So that's the reason why even if we find patients with a major alteration of the CT, we cannot predict from the CT if these patients will develop fibrosis afterwards. So remember, the lung morphology of chest CT, and even worse by chest X-ray, does not identify fibrosis in these patients. We identified 3 phenotypes in COVID-19. The first one is the so-called phenotype 1, the multiple focal with overperfused ground glass opacities and normally aerated areas, and mainly phenotype 3 with patchy RDS-like alteration, which are inhomogeneously distributed. Phenotype 2 is less frequent. We found that phenotype 1 was more likely to be treated with non-invasive respiratory support successfully, while phenotype 3 required the mechanical ventilation. In intensive care, when patients required intubation, we found that phenotype 1 was rare because the patients were treated by non-invasive respiratory support outside the ICU, while phenotype 3 was more frequent. And you can see different examples of that. So we look at the perfusion to better understand this pattern, and we use the dual energy computed tomography because it was the only technique at the bedside which was able to give us information about perfusion and really the blood volume distribution with a limited amount of radiation. This is a technique I don't want to enter into detail, but it's a very particular technique which includes 2 levels of voltage from 7 to 100 kilovolt and 150 kilovolt with a tube which is moving around the chest wall. And you can see here that especially if you give iodine, you have different coefficients of absorption, as well as if you consider the calcium, so the bone. So if you give iodine, and you measure the CT scan at 2 different energy, you may discriminate very well the amount of regional blood volume, even in the periphery. So this is an example of dual energy as a measurement of blood volume fraction. And this is the traditional perfusion. The difference is that with the dual energy, we can give an information on the distribution of blood volume through all the lung, while in perfusion is only one slice. And several studies showed that there is a correlation between pulmonary blood volume and pulmonary perfusion. And you see here in supine position, for example, how these 2 measurements are associated as well in prone position. So the blood volume very well reflect the perfusion in the lung. And this is our dual energy computed tomography. This was the first patient that we performed, and we can compare together the amount of aeration with perfusion. These are just some examples from the apex, from the lateral side, both lungs, and then you can put together the images from the lung to the perfusion. What we found is that the normal lungs weight is around 800 grams. In the traditional RDS is 1 kilo 800 grams, while the excess tissue mass in RDS is around 1 kilo. So in traditional RDS, we have almost 1 kilo of edema. In phenotype 1, you can see here that we found an increase in the weight, not too much. It's around 300 grams, while in phenotype 3, the increase in lung weight was around 1 kilo 600, and the excess tissue was around 800 grams. So the question is if this increase in excess tissue mass is edema or not. First of all, and this is a study that will appear very soon on critical care, we look at the distribution of normally aerated tissue, poorly aerated tissue, and non-aerated tissue from ventral to dorsal lung regions. And you see that there is a progressive increase in non-aerated tissue, so consolidated or collapsed in more dependent part of the lung, and a reduction in normally aerated tissue, while no change in the poorly aerated tissue from ventral to dorsal. But differently from traditional RDS, you can see here that the distribution of perfusion was anti-gravitational. So more perfusion in the ventral areas where we have more aeration, and this may also explain a further reduction in low VQ areas, and less perfusion in more dorsal areas, which in some way protect the respiratory function in terms of decreased amount of shunt. If we have more perfusion in the non-aerated tissue, we would expect more shunt. So we have a disbalance from ventral to dorsal in terms of normally aerated tissue and non-aerated tissue, and the distribution of perfusion was more in the ventral compared to the dorsal lung regions. This was the same from the apical to caudal regions, exactly the same. And then we will look carefully at the different components of aeration and perfusion. So you can see here that there is no much change from ventral to dorsal in terms of dead space. While the gas-blood ratio higher than 1 was prevalent in the non-dependent part of the lung, the gas-blood ratio below 1 was homogeneously distributed, while the amount of shunt was mainly in the most dependent part of the lung. Interestingly, we were able to measure in black the non-aerated and non-perfusion areas. So this is a sort of mechanism to protect the lung towards a further increase in shunt. And this was exactly the same when we look from apical to caudal. So when we look at the different kind of patients, from non-invasive respiratory support patients or invasive support, you see that we found that during non-invasive ventilation, so patients who were treated with non-invasive ventilation, are characterized by higher amount of normally aerated areas and a major decrease in non-aerated areas, while the amount of poorly aerated areas was higher also in the invasive mechanical ventilation. If we look at the different components, it's very clear that there was no clear difference between dead space and gas-blood ratio higher than 1. But as you can see here, there was higher amount of gas-blood ratio below 1 in non-invasive ventilation, while there was an increase in the shunted areas in invasive ventilation. So if we modelize that, we can say that patients who may maintain non-invasive ventilation are patients which hypoxia is mainly due to low VQ ratio, so the orange areas. Patients who require mechanical ventilation and such severe hypoxia are patients with true shunt and less low VQ areas. This is a very important consequence from a clinical point of view, because low VQ ratio may be treated with higher FiO2, shunt areas cannot respond adequately by increasing the FiO2. Another issue that I would like just to mention here is that if we move from phenotype 1 to phenotype 3, we have a progressive increase in the effort of the patients. And you see here that there is a progressive increase in the pleural pressure, in the negative pleural pressure, in the increasing respiratory rate and oxygenation increase. what we found is that oxygenation is very well correlated with the amount of non-aerated lung tissue. So if the PO2 F2 ratio is above 150, you see here that we expect an amount of non-aerated tissue above 30%. On the other side, if the PO2 F2 ratio is below 150, we would expect an amount of non-aerated tissue above 30%. So PO2 F2 ratio is a very good clinical indicator of the amount of aerated and non-aerated part of the lung, and if you are shifting from phenotype 1 to phenotype 3. This is a review which will appear very soon on BGA, in which we look at the pleural pressure in this patient. And you see here that if we have a major increase in the pleural pressure, we would expect, as you can see in the diagram below, in the non-dependent A and the dependent part of the lung B, an increase in the pressure in the interstitium. So the gradient between the capillary and the interstitium is greatly increased when the inspiratory swings are increased, while this is much less when the pleural pressure swings are minor. So this just focalized the attention on the fact that if we maintain spontaneous breathing with higher inspiratory effort, we completely break down the alveolar capillary barrier, we increase the interstitial pressure, negative interstitial pressure, and the gradient between the alveoli and the interstitial pressure, and this may promote further lung damage, and in that case, this may promote edema. Another issue that should be considered is the effect of PEEP, and what we found in this study was that most of the patients are not recruiters, so they do not respond to increased level of PEEP. And you see here that we found that alveolar recruitment in these patients, so the reopening of collapsed alveoli, was only 3% of the lung. And so we found that there was poor alveolar recruitment with higher PEEP in these patients, and the amount of recruitable tissue was only 40 grams in phenotype 3, with equivalent to 3% of the chest tissue mass, which is very much lower as compared to traditional RDS, in which recruitable tissue is almost 200 grams, which represents almost 20% of the chest tissue. So big difference from traditional RDS and COVID-19, more recruitment in traditional RDS, less recruitment in COVID-19. We found that there was no correlation between alveolar recruitment and excess lung weight, so it means that there was no correlation between the possible lung edema and recruitment, because lung weight increase in COVID-19 is not due to edema, while in traditional RDS, we can find a very good correlation because alveolar recruitment is due to the increased edema. There was no correlation between alveolar recruitment and oxygenation at the baseline, as well as no correlation between alveolar recruitment and respiratory compliance. So we cannot predict any amount of recruitment in COVID-19, and the amount is very minimal. Overall, when we compare the oxygenation at lower FiO2 0.5, increasing the level of PEEP, or as in the right panel, at a higher level of FiO2 and lower PEEP, you can see that we got higher level of PO2 when we increase the FiO2 as compared to the increase on PEEP. So it's always better to increase the FiO2 as compared to increase excessively the pressure in these patients, because you can see here that the respiratory compliance decreased in all patients in which we measured compliance at higher level of PEEP. And also we found that alveolar recruitment was not correlated with the change in venous admixture. So this means that the change in venous admixture, so changes in oxygenation in COVID-19 with PEEP are mainly due to the decreased cardiac output and the redistribution of regional perfusion, but not alveolar recruitment. These are very important data which are submitted and probably accepted soon, in which we compare the delay in intubation. This is very important from clinical point of view. We compare patients in which intubation was performed within 2 days of hospitalization with severe respiratory failure, and patients with late intubation, so in which we applied helmet CPAP, so non-invasive respiratory support, for more than 2 days on a median of 7 days. First of all, we found that the excess lung tissue mass, when measured at the CT, was higher in the patient in which intubation was delayed. And further, when we look at the different parameters, you can see here that the total gas volume was higher in the early intubation. The tissue volume was lower. The normally aerated tissue was higher, while the poorly aerated tissue and non-aerated tissue was lower when patients were intubated early as compared to late. And as a consequence, oxygenation and compliance were much better when we intubated early patients as compared to late. And there was no difference in terms of recruitment, you see 8 to 16, in whatever components of the CT scan between early and late intubation. This means that if we delay intubation, the disease is progressively, and the progression is not to do the real edema, but is a consolidation of the lung. This is just to remind you that prone position was used very frequently in this patient in non-invasive ventilation or control mechanical ventilation. And two mechanisms have been proposed: the flow diversion, so no change in the density redistribution, but a change in the perfusion, or effective alveolar recruitment. What we found, and this is another study in preparation, we performed CT scan in supine and prone position, and we found, as you can see here, that there was no redistribution in the densities. So this means that the flow diversion was the main mechanism, in our opinion, explaining the improvement in oxygenation and not effective alveolar recruitment. So we have to be very careful when we prone the patient, especially non-invasive respiratory support. These CT scans were performed during non-invasive respiratory support because the improvement in oxygenation may even delay the intubation. Of course, we can do that if we have a lack of ICU beds. This is a study in which we look at the compensation between systemic and cerebral oxygenation. This is recruitment maneuver, and you see in blue the oxygenation before and after, in orange the PCO2, in dark blue the oxygen in the brain, and in gray is the estimation of intracranial pressure. You see that recruitment maneuver was associated with no change in the systemic oxygenation, a decrease in the oxygenation in the brain, and an increase in intracranial pressure. So we do not recommend recruitment maneuver in these patients. When we use prone position, we found an increase in oxygenation, as you can see here, which was parallel in the brain, not so much as we expected, but also an increase, even moderate increase, in the intracranial pressure estimated by the nerval sheath diameter. So prone position has to be performed, but very cautiously in these patients. We got very interesting results with inhaled nitric oxide, in which we found an improvement in oxygenation less than in prone position, but also associated with improvement in oxygenation in the brain, and no changes in the intracranial pressure. When we use echo to R, so methods in order to wash out the CO2 from outside, interestingly, we found that we need less mechanical work, so less ventilator-induced lung injury, but we also observed a reduction in oxygenation, likely due to the fact that the rapid change in pH may alter the epoxy vasoconstriction. So take care of the change in pH. When the pH increases, the epoxy vasoconstriction decreases, especially in COVID-19 patients. So the model that we developed is that COVID-19 patient is a typical primary ARDS with a complete disorganization of memory and vascular lysis, and there's a great thank to Professor Gustavo for this intuition. And the gas volume is substituted by cellular necrosis, cellular infiltration, and fibrosis, and there is no recruitment when we apply higher PEEP, and the improvement in oxygenation may mainly due to a redistribution in perfusion. The hypoxia and wasted ventilation has been clearly described in our studies. Actually, we know that low vacuum is in poorly aerated lung tissue, mainly due to hyperperfusion in the non-dependent lung regions. The true shunt in non-aerated lung tissue with microthrombosis vascular lysis effect, which might be even partially protective. I show you some areas of non-perfused lung in the non-aerated lung, and high VQRS in the poorly aerated tissue, mainly due to hypoperfusion and leading to wasted ventilation. So hypoxia is characterized by low lung weight, low lung recruitability, high compliance with low inspiratory effort, high vasonac mixture, but mainly to do the low VQRS, and of course, high wasted ventilation with high VQ and dead space in the poorly aerated tissue. So in this patient, we have a good response to FiO2, and so the non-invasive respiratory support is the first choice. While unhappy hypoxia is characterized by high lung weight and low recruitability, but low compliance, so high inspiratory effort. And the high venous admixture is mainly due to the true shunt in the non-aerated tissue and much less to the low VQRS in the poorly aerated tissue. So you have a poor oxygenation response to high FiO2 and high pressure. So these patients require intubation. So if you want to simplify, epipoxia is a phenotype 1. We need oxygen with high flow oxygen nasal therapy. This was our first choice. Then CPAP by mask of helmet or non-invasive positive ventilation. But when we are moving to unhappy hypoxia with phenotype 3, we require early intubation. Just briefly, the last 2-3 slides. This is our protocol, which might be of interest for everyone on what we did in the ward. So we look at the saturation in the room air. We made an oxygen test, and then eventually a HFO, so high flow oxygen nasal therapy, and CPAP test. And if oxygenation was below 95%, with FiO2 higher than 60%, we decided to intubate, especially if the respiratory rate was higher than 28. Of course, other parameters might be considered, including the reduced PCO2 and the activity of accessory muscles. In that way, we were able to, we don't know if avoid, but we intubated a relatively minority of the patients treated in the ward. So don't delay intubation if the patients are worsening, especially in terms of oxygenation. There are some scores that may be used, like the HACR score or other scores that might be used, considering the heart rate, the pH, the Glasgow Coma Score, the PaO2, and the respiratory rate. This is a paper that I suggest all of you to look at. We recently published making a sort of summary of the treatment of this patient, but mostly for patients intubated and in non-invasive support is to maintain, and I think that Professor Zubieta will discuss this later, to maintain minimal oxygenation in this patient, not looking for too high level, and this may save also a large amount of oxygen in our patients. There are some consequences of that, the possible Bohr effects, so that we have a decrease in saturation for the same amount of oxygenation. That's the reason why we use very frequently the ECHO2R, so low flow CO2 removal, in order to maintain the pH and PCO2 constant at lower amount of oxygen to avoid the Bohr effect. On the other side, we need to increase a little bit the amount of hemoglobin in order to maintain the oxygen transport. Here are some calculations that shows that we need a hemoglobin at least higher than 8 to 10 grams per deciliter in order to maintain adequate oxygen transport in these patients. So to conclude, COVID-19 is a really serial killer, is a very systemic complex disease, it's not traditional RDS. The first bullet is a primary RDS, and as discussed and shown by Professor Zubieta, may be described as a pneumo and vascular lysis. The second bullet is coagulation with thrombosis and also hemorrhage. And the third bullet is fibrosis, but I show you that fibrosis cannot be expected or predicted from the chest X-ray. And there are three main targets in our opinion: corticosteroids, anticoagulants, not only prophylactic, but also by treatment, and protective respiratory support, and local protocols are very important. Phenotype 3 is more frequent than phenotype 1 in critically ill patients. There is an inhomogeneous pattern of aeration and volume distribution and perfusion defects, as I show you, and the different pattern is associated with outcome inflammatory and thrombophilia. We were able to clarify that in the hypoxia, we have higher compliance and low VQ areas, more response to IFR2. In the hypoxia, we are characterized by lower compliance and decreased respiratory effort and high true shunt and less low VQ areas. So how to ventilate this patient? This is my last slide. B patient, we need long time of ventilator support in COVID-19. In phenotype 1, we started with non-invasive respiratory support, but early intubation is needed if clinical parameters are deteriorating. Don't wait too much. In phenotype 3 and phenotype 1, not improving with non-invasive support, we suggest, and I show you several data, early intubation and control mechanical ventilation with very protective ventilation with minimal level of PEEP between 8, maximum 12 centimeters of water, a plateau pressure below 27 and driving pressure below 12 to 14 centimeters of water. Don't use higher level of PEEP than 15 centimeters of water, and don't use recruitment maneuver, but you have to privilege, at least this is our opinion, higher level of FR2. We have to minimize the oxygenation target. This is very important, allowing a higher level of hemoglobin in order to improve oxygen transport and to keep, if not possible with traditional ventilation, the control, especially in phenotype 3 of CO2 by using, for example, echo 2R, so low flow CO2 removal. You can try prone position, but remember, in most of cases, the effect is mainly due to perfusion redistribution, and you can lose the positive effects when the patient is repositioned as supine, and we can consider inhaled nitical site. Finally, we found that respiratory physiotherapy in the weaning phase and in the immediate phase after extubation was very important. Thank you very much. I tried to give you an overlook of our interpretation of COVID-19 and some clinical consequences. Thank you.
Yeah. Thank you very much. Thank you very much, Professor Paulo. It was an extraordinary talk you have given, so lucid. It is an interesting as such. I request Chairperson, Dr. Vidya.
It was a beautiful talk, sir, Paulo, sir.
You just take one question and then we'll go to the next speaker. So we'll proceed it. Okay.
Okay, sir. Actually, I have 2-3 things to ask, but then I'll restrict myself to just one question, sir. Sir, you said there is weight increase not due to edema. Then what else it is due to, sir? Consolidation is, it is only the alveoli form the consolidation. Something has to add up to increase the weight, sir. So what is that if it is not the fluid?
Yes, it is a sort that I showed you is this mucosinosis, so very gelatinous or dense material due to the necrosis of the interstitium and the epithelial and capillary side. So it's a sort of big necrosis of the lung. While in the traditional RDS is the alveolar capillary permeability damage with edema. Then you can have a combination of factors, but mainly what we found is that a real complete necrosis of the lung. So that's why we are not so much convinced anymore about so much important of microthrombosis. In our samples, we did not find so much microthrombosis. It's possible that you have microthrombosis, of course, if you don't use therapeutic anticoagulation. But in our patients, we use therapeutic anticoagulation, and we published one study, even recently, the first name is Lavinio with Chiara Roba from our team, in which we showed that therapeutic anticoagulation, of course, according to higher dose of enoxaparin, according to the D-dimer, the TAG, etc., was able to have an association with better survival. So this is very intriguing factors, but the main message to me is that we did not find that edema, the classical edema, was the main mechanism for the increased lung weight. Otherwise, we should have expected also higher amount of recruitment that we did not find in our patients.
Yeah.
Thank you, sir.
Thank you very much. I just request that any young doctor, any young doctor at the level of assistant professor can ask one question. It's an opportunity to ask a question to a legendary professor of anesthesia like Dr. Paulo Pelosi. One young professor, assistant professor or associate professor. Anyone?
I see a question here.
Yeah.
Sorry.
One question is there. Yeah, anybody? Any young?
Sir, Dr. Nitin Agarwal here.
Dr. Nitin. Okay. Yeah, please
Can
ask.
I ask one question?
Only one question.
Sir,
yes.
Excellent talk, sir. Sir, one query which we have seen practically, even with PEEP 8 to 10, there is a barotrauma and pneumothorax is very commonly seen in these cases. So even with PEEP of around 10.
Yes, this is an important question. We also found that especially even during non-invasive respiratory support, that I mentioned, there is this bigger paper that we publish on BJA, it will appear soon, that we found that there is a real patient self-inflicted lung injury. That's the reason, because this is necrotic. And I show you the lesion in the periphery. And the periphery means also mediastinum. In fact, you have pneumothorax and pneumomediastinum, even during spontaneous breathing. So that's the reason that we have to limit it, in our opinion, spontaneous breathing, especially if the patient is not improving, because otherwise you are activating all these deteriorating mechanisms, and this may lead, you are absolutely right to that. And when you develop pneumothorax or pneumomediastinum in these patients, it's very severe, because you have a real necrosis of the periphery of the lungs. It's not like the conventional barotrauma. So it's like a crater, a hole, like the volcano. So this is very difficult to treat. We try to treat with echo 2R, some cases with ECMO, but it's very hard. So it's better to prevent the pneumomediastinum and pneumothorax. And one of the reasons, in our opinion, is to reduce the time of spontaneous breathing when the patient is not improving. I see a question.
Okay, thank you. No, yeah, please, Professor Paulo.
Brief thing, Paulo. Very beautiful talk, as usual. Fantastic. One of the top world experts, without doubt.
No doubt about that. No doubt about that. It is true.
Yes. So just one brief comment. The necrotic tissue does have water. So it is edema mixed with the necrotic tissue. I believe water is there, of course, but the necrotic tissue is absolutely pneumolar vascular lysis without doubt.
Gustavo, in fact, this I think is that we have the concept of edema, because we have the concept of the traditional RDS. That for us is edema. You are completely right. Yes, I'm not saying that there is no water around, but the components of necrosis, I mean, we can say a sort of trash, in the area is worse. And this is not what happened in the traditional RDS. And that's explained fully. You see all the papers that we are doing now, almost published time by time, by CT, they are exactly on the same line. So means that I think these data are very strong. And of course, we are open if other people will challenge them.
Thank you very much, Professor Paulo. Thank you, Dr. Gustavo. Thank you, Vidya. I think now that we have to go to the next. So first, I request Anand. Yeah, please upload the certificate. I request Dr. Vidya to confer the certificate of honors from the organizers from the BLD University and IPPA Zubieta jointly. Please upload. I request Dr. Vidya to confer.
Yes, sir. I confer, sir. I'm very much pleased and I'm fortunate to be doing this duty of mine. It's my honor.
I will send the certificate by email attachment to Paulo tomorrow. Thank you, Professor Paulo.
Thank you. Yes. I stay here. I want to,
yeah. I will send you tomorrow, or by just after that, I will send you by WhatsApp. Okay. So thank you very much, Professor Paulo, for your extended lecture, and Dr. Vidya. And I request Professor Paulo to hand over Dr. Vidya.
Yes, sir.
Getting the certificate you'll be getting the certificate of recognition from BLD University and IPPS jointly. Anand, you are having
Thank
the
you, sir.
Yes, sir. Yes, sir.
please upload. Yes, Professor Paulo, please hand over the certificate digitally to your chairperson, Dr. Vidya.
Yeah, no, I did not understand.
Yes, this is a certificate you are
You are receiving.
Yes, sir.
You
I'm
are
receiving.
receiving
Sir.
this certificate, Paulo, for your talk.
Ah, thank you, perfect.
Yes,
Beautiful.
thank you very much. Thank you very much.
Thank you.
Yeah, so I request now we go for the next lectures
Thank you.
that will be given by Professor František Kolar, and I request Dr. Sanjeev Sajjanar, who will be chairing the session, Associate Professor of Cardiology, CBM Patil Medical College, BLD. And Dr. Sanjeev did his MBBS from BLD Medical College. He's an alumni of BLD University, and he did his MD from KIMS Hubli and BM Cardiology from Topiwala National Medical College, Mumbai. Over to Dr. Sanjeev. Dr. Sanjeev Sajjanar. And
hello, good evening, everybody.
yeah, good evening.
Hello.
Yeah, you are audible. You
Good
please
evening,
now,
everybody.
please now
Good
invite.
evening, everybody. It's my privilege to introduce Professor František Kolar. He's an eminent physiologist, and sir is a professor and deputy director of Lab of Developmental Cardiology, Institute of Physiology, Czech Academy of Science, Prague. Professor František Kolar graduated from Charles University in Prague in 1977, and sir received PhD degree in 1985. Sir was appointed as full professor of medical physiology at Charles University in Prague, and later sir became head of the Department of Developmental Cardiology at Czech Academy of Sciences. Dr. Kolar is a member of several international societies, like International Society of Heart Research, International Society for Chronic Hypoxia, Society for Experimental Biology and Medicine, and International Academy of Cardiovascular Science. Sir is currently on editorial boards of Experimental Biology and Medicine and Physiological Research. Dr. Kolar received awards from Czechoslovakia Cardiological Society, Czech Physiological Society, Ministry of Health, Czech Republic, and Slovak Academy of Science and International Academy of Cardiovascular Sciences. Sir is a recipient of Science, Honor and Truth Medal from IPPA La Paz. Sir's early research concerned with the role of skeletal muscle in catecholamine-induced thrombogenesis, and after joining Institute of Physiology, Sir's main research interest focused on early postnatal development of heart with particular respect to cardiac contractile function, calcium handling, and humoral control. More recently, Sir became interested in myocardial tolerance to acute ischemia, reperfusion injury, and in normal and diseased heart, and in particular in the mechanism of sustainable forms of cardioprotection induced by adaptation to chronic hypoxia and regular exercise. So Dr. Kolar has published more than 223 in Scopus reviews and book chapters. Sir's Scopus H index is 33. So I'm very privileged to introduce and present to you Dr. Professor František Kolar. Sir will be speaking on cardioprotective effect of chronic hypoxia combined with exercise training. Sir, over to you, sir.
Thank you, sir. Professor Kolar, Professor František Kolar.
So good morning, good afternoon, good evening to different parts of the world. Do you hear me, please?
Yes, 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 yes,
Perfect.
Professor Kolar.
Good. So first of all, I wish to thank for this very nice introduction. And I also would like to thank to Professors Kusal Das and Gustavo Zubieta for inviting me to participate in this tribute to Professor Biradar. I met Professor Biradar only once about 2 years ago during the chronic hypoxia symposium in Bolivia, and I remember him as a very nice person and distinguished physician. His passing is a great loss, not only to the university, but to the whole medical and scientific community. I understood that the main topic of today's lectures is COVID-19, but I don't feel, unfortunately, qualified to talk about COVID. As you see, my talk will be about chronic hypoxia and its effect on the heart. So quite different topic, but of course there are clear links between chronic hypoxia and COVID, but I will leave this to Professor Zubieta. In the following lecture, Professor Ramirez will discuss the good and bad side of hypoxia, but I will focus only on the most important good side.
Hello, please unmute. Those who is not speaking, please unmute. Yeah.
I will focus only on the most important good side of chronic hypoxia, and that is cardiac protection against injury. You know that beneficial cardiovascular effects of chronic hypoxia were recognized already in the middle of the last century when the first epidemiological observations were published and summarized, indicating that the incidence of myocardial infarction is lower in people who live high in Peruvian mountains, and this advantage is lost when they move to the sea level. Several subsequent studies confirmed beneficial cardiovascular effects of high-altitude hypoxia, and I mention here only two of them published more recently. It has been shown, for example, that living at higher altitude significantly improves survival of patients after heart transplantation, which is perhaps quite intriguing observation. And this is the study which analyzed more than 12 million death records in the United States, which concluded that living at higher altitude.
Professor Kohler, yes, yeah. Sorry for interacting. Can you go for slide sharing? Means can you go for the full screen slide?
Okay.
The presentation mode.
I will try.
If you do not try, don't bother. You go ahead if it is.
Yeah.
Yeah.
Is it okay?
Yeah, it's fine. Fantastic. Yeah. Very good.
Sorry, I am not experienced with Zoom. We usually use another platform, so I apologize for
not at all
any problems.
Please go ahead.
This study analyzed, as I said, more than 12 million death records in the United States. And it concluded that living at higher altitude decreases mortality from ischemic heart disease. And it is shown clearly on the graph, which shows the beneficial association of altitude with the death rate for ischemic heart disease, adjusted for a number of factors other than altitude hypoxia. Living in the mountains is usually associated with more physical activity than at sea level, which is also good for the heart. Both chronic hypoxia and exercise have received an increasing attention as natural, well-tolerated, and clinically relevant stimuli that can induce much prolonged window of cardioprotection. It means improved cardiac ischemic tolerance, which persists long after the initial stimulus. Detailed understanding their protective mechanisms may therefore offer greater potential for translation than various short-lived forms of cardioprotection, such as preconditioning and so on. Unfortunately, our knowledge in this field is still quite incomplete. Although chronic hypoxia and exercise obviously share several important signaling pathways leading, for example, to increased antioxidant defense, limited evidence exists suggesting that there are some differences in protective mechanisms. In particular, while chronic hypoxia stimulates moderate pro-inflammatory signaling, exercise may inhibit the inflammatory response. And it is unknown whether these two protective measures can act in synergy in improving myocardial survival of ischemic insult. So we wanted to check whether regular exercise training of rats in chronically hypoxic environment can confirm stronger additive cardioprotective effect than hypoxia or exercise alone. And we focus on the role of redox and inflammatory pathways related to tumor necrosis factor alpha. In the first part of my talk, I will briefly summarize our data showing that moderate levels of TNF-alpha and reactive oxygen species are necessary for the induction, for the triggering of ischemia-resistant phenotype of chronically hypoxic hearts. Rats were exposed to hypoxia, 10% of oxygen, under normobaric conditions, continuously for 3 weeks, and controls were kept in room air. And half of the animals in each group were treated with infliximab. This is monoclonal antibody against TNF-alpha during the whole adaptation period. And separate groups were used for biochemical analysis and for myocardial infarct size determination following 20-minute coronary artery occlusion and 3 hours of reperfusion in open chest model to induce myocardial infarction. This slide shows TNF-alpha levels in myocardial cytosolic and membrane fractions from normoxic and chronically hypoxic rats, untreated and treated with infliximab. And you see that chronic hypoxia equally increased this pro-inflammatory cytokine level in both fractions, which was completely prevented by infliximab treatment. And here you can see the key results showing that chronic hypoxia reduced myocardial infarct size compared to normoxic controls. And infliximab abolished this protective effect without affecting normoxic hearts. TNF-alpha mediates his actions through type 1 and type 2 receptors, while chronic hypoxia had no effect on this low affinity type 1 receptor. It strongly increased the expression of type 2 receptor, which has been shown to be protective against ischemic injury in another settings. Infliximab abolished this effect. So it suggests that chronic hypoxia activates protective signaling of TNF-alpha type 2 receptor without affecting detrimental signaling of type 1 receptor. Stimulation of type 2 receptor by membrane-bound TNF-alpha can induce transcription factor NF-kappa B, and this is what actually happened in chronically hypoxic hearts, where NF-kappa B expression was markedly elevated. Again, infliximab completely abolished this effect, suggesting a potential link between TNF-alpha, its type 2 receptor, NF-kappa B, and cardioprotection by chronic hypoxia. Inducible nitric oxide synthase and cyclooxygenase 2 are important mediators of delayed forms of cardioprotection, but their increased expression in chronically hypoxic hearts were not significantly affected by infliximab. Other potentially cardioprotective molecules, such as NF-kappa B activated monocyte chemoattractant protein, hemoxygenase, and aldehyde dehydrogenase 2, were affected by neither chronic hypoxia nor infliximab. It has been suggested that protective signaling driven by TNF-alpha involves reactive oxygen species produced by mitochondria, where manganese superoxide dismutase is the dominant antioxidant enzyme. And you see that chronic hypoxia led to oxidative stress, as indicated by lipid peroxidation, protein nitrosylation, and most importantly, to increased expression of MNSOD, manganese superoxide dismutase, mitochondrial antioxidant enzyme. And all these effects were abolished again by infliximab treatment. So the upregulation of MNSOD could be the key cardioprotective action during adaptation to hypoxia that is dependent on ROS formation induced by TNF-alpha. And this view is supported by data from our earlier experiment on chronically hypoxic rats treated during hypoxic adaptation with the antioxidant and acetylcysteine, which also abolished the protective effect. The treatment was terminated 24 hours before coronary occlusion to avoid any potential acute effects of the drug. And regression analysis indicates that infarct size negatively correlated with MNSOD activity. The higher activity was associated with smaller infarction, likely due to more efficient disposal of superoxide generated by mitochondria during the ischemia reperfusion insult. So the simple conclusion from these experiments is that chronic hypoxia is associated with increased TNF-alpha and ROS formation, and these responses are necessary for the induction of ischemia-resistant cardiac phenotype, which likely depends on the improvement of antioxidant defense. This is just a graphical, simple expression of this conclusion. It should be noted that besides TNF-alpha and reactive oxygen species, there are also other factors such as catecholamines, which play a role in cardioprotection. While the uncontrolled excessive surge of these basically bad guys can be detrimental and result in maladaptation, their moderate levels stimulate protective signaling and result in the infarct size reduction. And because they are mutually linked together, the inhibition of any of them prevents the development of ischemic tolerance of chronically hypoxic hearts. Of course, this is a greatly oversimplified scheme. There are many other players in the cardioprotective mechanism. So now we can move to the second series of experiments, which aimed to find out whether chronic hypoxia combined with exercise training can confer additive cardioprotective effect, and to examine the role of TNF-alpha and ROS-dependent signaling. Rats were adapted this time to 12% oxygen continuously, again for 3 weeks, and half of them were forced to run on a treadmill for 60 minutes per day, starting the second week of hypoxia. After 1 week of habituation, the speed was set at 30 meters per minute till the end of the hypoxic adaptation. And control animals were trained in room air under the same conditions. Again, separate groups were used for biochemistry and for infarct size determination. The graph on the left side shows myocardial TNF alpha levels in sedentary S and trained normoxic and chronically hypoxic rats. You see that exercise had no effect in normoxic group, but it prevented or at least significantly attenuated the increase of TNF alpha induced by chronic hypoxia. Another inflammatory cytokine, interleukin 6, exhibited a very similar expression pattern as TNF alpha. Regarding TNF alpha receptors, neither chronic hypoxia nor exercise affected the expression of type 1 receptor, while the upregulation of protective type 2 receptor by hypoxia was absent when combined with exercise. So the effect of exercise was similar to that of infliximab, to TNF alpha blockade in the previous experimental setting. The expression of NF-kappa B was again increased by chronic hypoxia, and this increase was reduced by exercise training, which had no effect in normoxic rats. But it should be noted that the TNF alpha level still remained significantly higher in rats exercising in hypoxia compared to their normoxic counterparts. Interestingly, exercise had no effect on the upregulation of inducible nitric oxide synthase in the hypoxic group. These are some other TNF alpha related molecules which are involved in inflammatory signaling and can play a role in delayed forms of cardioprotection. Cytosolic phospholipase A2 alpha was activated by chronic hypoxia alone, but not by hypoxia combined with exercise. The upregulation of cyclooxygenase 2 induced by chronic hypoxia was also markedly reduced in exercising rats. But unlike COX-2, COX-1 didn't show any difference among the groups. These graphs show the marker of oxidative stress and the expression of antioxidant enzymes. Chronic hypoxia again resulted in lipid peroxidation, while exercise had no effect in any group. Both catalase and manganese superoxide dismutase were upregulated by chronic hypoxia, and the increased level of MNSOD still persisted in exercising animals. It was slightly reduced, but still much higher than in the control non-hypoxic groups. So the absence of any significant effect of exercise on redox state and antioxidant defense stimulated by chronic hypoxia, despite the inhibition of TNF alpha, is in contrast with the complete elimination of all these effects by infliximab. And finally, here are data on myocardial infarct size. Exercise training alone significantly decreased infarct size compared to the sedentary normoxic group, while chronic hypoxia alone tended to provide somewhat stronger protective effect. However, the infarct size was the same in both groups of hypoxic animals, regardless whether they exercised or not. So exercise training preserved the infarct size limiting effect of chronic hypoxia, but didn't provide additive protection. We can conclude that regular exercise training of rats during their adaptation to chronic continuous hypoxia conferred the same infarct size limiting effect as hypoxia alone, despite significantly attenuating hypoxia-induced increase in TNF-alpha dependent cardioprotective signaling. The maintenance of ischemia-resistant cardiac phenotype in chronically hypoxia combined with exercise can be possibly attributed to the persisting increased capacity of myocardial antioxidants due to other mechanisms unrelated to TNF-alpha. Finally, I would like to acknowledge all my co-workers from these two institutions who have contributed to the study, from the Academy of Sciences and the Charles University in Prague, and also the Czech Science Foundation for support. And I thank you for your attention.
Thank you. Thank you very much, Professor František Koller. Brilliant talk, and we so lucidly explained. I like to inform all of you before I go to the chairperson that other side of Professor František Koller, he's an extremely human being. Recently, one of my former student, who is a surgical oncologist, his son, who is studying medicine in Prague, has some problem with the COVID-19 and all. So I have contacted Professor František to find out, because there are no information from his end, because he was hospitalized or somewhere he was. So Professor František took all steps to contact the boy and got all information and feedback to me, which in turn I feedback to his father and mother. So that's the other side of Professor František Koller I want to share with you. Over to Dr. Sanjeev.
Thank you, sir. It was a very lucid presentation. In detail, you explained regarding molecular biology involved in cardioprotection in chronic hypoxia and exercise. So all these studies were done in rats. So one question is, we can extrapolate all these findings to the human beings?
Well, this is always the difficult question, you know. In fact, these experiments were only secondary to some observations found in human beings living at hypoxia of the mountains. These were the primary observations that myocardial infarction is less in people who live in the high mountains. The experiments were only secondary to these observations, trying to explain the mechanisms by which chronic hypoxia can protect the heart. Of course, we cannot say whether the factors and the compounds which we found effective in rats will work in humans. But obviously, this is the idea, to find the target, to find the final targets, the molecule which is targeted by chronic hypoxia, and to try to whether it would be effective in humans. But this is still far away.
So
thank you, sir. Thank you very much.
Thank you very much. I just request one young assistant professor or associate professor in that level, or young doctor, can you ask one question? That's the last question.
Good evening, sir. Myself, Dr. Sri Lakshmi Bagli, Associate Professor from the Department of Physiology. First, I would like to congratulate sir for the very brilliant presentation. And during my PhD, I have worked on similar lines, that is chronic hypoxia and cardiovascular remodeling under mentorship of Professor Das. And I have one question, sir. Literature suggests that hypoxia acts as a double-edged sword. In some of the cases, it stimulates the adaptive signaling, and in some others, it stimulates the maladaptive signaling. Yep. So what decides, or what factors decide which of the signaling mechanism is activated? Like in your study, it was adaptive signaling. But some studies have shown that the animals go into a cardiovascular remodeling, then heart failure. So
Yeah.
what are those factors which determine which of the signaling mechanisms are activated?
Yeah, you are absolutely correct. Yes, yes. Thank you for this question. I think the main problem is in the models of chronic hypoxia, in the animal models which are used. This model which we used was a continuous hypoxia, continuous normobaric hypoxia. But often there are some models of intermittent hypoxia, hypobaric hypoxia, and there might be some differences. For example, if we interrupt every day the hypoxic exposure of the rats by just 1 hour of reoxygenation, 1 hour of normoxia, the protection is completely lost, because probably it's related to the role of hypoxia inducible factor alpha, which is disrupted by this 1 hour reoxygenation. So I cannot give you a clear answer what distinguishes protective and bad effect of nitric oxide on the heart under conditions of chronic hypoxia. But I would expect that the model, the specific model of chronic hypoxia and the animal species may play a role.
Thank you so much, sir.
Thank you so much, Professor Kohler. You have taken so much of time to be with us and honor.
Good evening, sir.
Yeah, I think, Dr. Shaheen, that we have to go to the next session. Time is fixed. So I will request you can ask any questions. So I will forward the email ID of Professor Francis Kohler. You can share with him. Okay. So
thank you very much.
Thank you, sir.
Yeah, Dr. Gustavo, I think let us conclude Professor Francis Kohler's session. And I request now Anand, Mr. Anand. Yeah, please. I request now chairperson of the session, Dr. Sanjeev. I thanks to Dr. Sanjeev for excellent chairing the session. Now you please present online, virtual, the certificate of honors to respected Professor Francis Kohler.
Please receive it, František.
Oh, thank you. Thank you very much.
We are greatly honored and we are humbled of your presence in spite of your busy schedule. Thank you, Professor.
Thank you very much.
I will send all these things to Professor Gustavo and directly to you also. And I now request Anand to please put the certificate of recognition to Dr. Sanjeev Sajjanar. Yeah. So on behalf of Francis Kohler, the chairperson, this is the recognitions to Dr. Sanjeev Sajjanar, Associate Professor of Cardiology of our medical school. Thank you, Dr. Sanjeev.
Very nice. Thank you very much.
Thank you very much. Now we can go to the next session, that third session. I request Dr. Bashavraj Paradal. Now third session speaker is very much known to BLD because he visited 2019 along with Professor Gustavo Zubieta. He is none other than Jan Marino Rino Ramirez. So Professor Nino is with us, and now I will request Professor Dr. Bashavraj T. Baradel, who is the neurosurgeon by profession, and he is currently Assistant Professor, Department of Surgery, BM Patil Medical College, did MBBS from BM Patil Medical College. He's our own alumni, and MS Surgery from Government Medical College, Coimbatore, and did MCH, Neurosurgery from NIMS, Hyderabad. Over to Dr. Bashavraj T. Baradel.
Thank you, sir. And thank you giving me this opportunity to speak about a world-renowned and dedicated his life to the field of research, Professor Jan Marino Ramirez, popularly known as Nino. Professor Jan Marino Ramirez is a professor of neurological surgery, joint professor in pediatrics, and adjunct professor in Department of Pathology and Department of Physiology and Biophysics at the University of Washington School of Medicine. He serves as a director of Center for Integrative Brain Research at Seattle Children's Research Institute. Nino, born in Lima, Peru, Ramirez moved to Germany at the age of 6, and early on he was drawn towards ethological questions and fascination that was inspired by reading books from Conrad. And he was puzzled with the questions how the brain generates emotions, thoughts, and consciousness. And he felt that understanding a simple movements may be the best strategy to gain solid insight into the working of the brain. And combining his interest into the music and his these musical waves he has very much observed in the brain movements also. So he went into the deep into the research field. And together with his wife, Nino studied biology and completed his undergraduate and graduate studies in the neuroethology at the University of Rosenberg. In 1996, Nino accepted a faculty position at the University of Chicago, where he moved up to the ranks from assistant to full professor and ultimately to chair of the Department of Organismal Biology and Anatomy. And at the University of Chicago, he taught gross anatomy to medical students and neuroscience to undergraduate students. In his research, he described reconfiguration of the respiratory network as it generates breathing, gasping, and chewing. In Chicago, Ramirez also began to apply his scientific experts to the clinical issues. Working with Debra Wismer, he studied erratic breathing and cardiorespiratory coupling in Rett syndrome and familial dysautonomia. And with Wim van Roland, Ramirez worked in epilepsy in focal cortical dysplasia and Kamal-Noje FCD. And in 2008, Nino was recruited by the Department of Neurological Surgery, University of Washington, to establish a neuroscience center at the Seattle Children's Research Institute. And he was effectively studied in the respiratory overstimulation and sudden infant death syndrome and mitochondrial disease and anesthesia. He has a 167 Scopus publications with 50H index. And Professor Nino is associate editor to the Journal of Neurophysiology in 2014 and reviewing editor of eLife since 2015 and editor-in-chief for the Journal of Neurophysiology. And here introduce Dr. Professor Jan Marino for the speaker. Thank you, sir.
Thank you so very much for the very nice introduction. And it's a great honor to present to you a talk today in this context. And maybe I try to share, 1 second.
Yes, perfect.
Thank you so much. Yeah, it is really with great sadness that I give this talk because during my visit to Bolivia and to my visit to India, I had the immense honor to meet Dr. Biradar. And as you know and heard already, he has been a leading clinician and a remarkable administrator. And I have to tell you that in my meeting with him, what impressed me most is that, you know, he was the vice chancellor of an esteemed university, but yet he was extremely humble. He never put himself first. I mean, he would listen, he would be here, you know, to give advice, to share his wisdom, but he never put himself first. And he was what I call, you know, a leader that is there to serve. And so when I found this sentence here, I felt that this is exactly what we are doing here. A great soul serves everyone all the time. A great soul never dies, and it brings us together again and again. And I think today is one of these occasions where we're coming back again, thanks to Dr. Biradar, and he will stay with us in the community forever. And it has been a great, great honor to meet him. And it's just unbelievable that we had to lose him so early. And he has been a great mentor to all of us. And so it's a great honor to give this talk in this context. And in this context, I want to focus on actually the bad side of hypoxia. And you heard about the good side, and which is really the chronic hypoxia, and the bad side, which is intermittent hypoxia. And there's a dramatic difference. And I hope to explain this in my talk today. Now, why is oxygen so essential? Now, oxygen is essential in particular to keep our brain active. And here you see a recording from a brain, an awake brain, and you can see how active this brain is. That all these neurons are continuously active, whether we are awake, whether we're sleeping, when we close the eyes, whether we don't hear anything, the brain in every area is continuously active, and it needs oxygen. And this activity in the brain is actually coordinated with breathing, which provides this oxygen. And this is a beautiful recording from the prefrontal cortex, which is important for higher brain functions. And you can see that the activity in this prefrontal cortex is oscillating in phase with breathing and in phase with inspiration. So basically, when you're inspired, indeed, your brain is inspired. Now, breathing also plays an important role in arousal. These are neurons that are generating the sigh, and they're closely interacting with the adrenergic C1 neurons. And each time you sigh, basically this noradrenergic push to the brain causes an arousal. So 95% of the time when you wake up at night, you wake up with an arousal. Again, evidence for the interaction with breathing and the brain. Now, vice versa, the brain also informs the breathing. So when I talk to you, it's actually a breathing behavior. I take a breath, and then when I use this air to talk to you, it's timed and coordinated by the brain. Now, where everything comes together is an area, a very small area in the brainstem, which is called the Pre-Bötzinger complex within the medulla. It's an ventrolateral medulla, and it is essential for breathing. So if you lesion this in an animal model, then breathing stops, and that has been reproduced in many, many different systems. So because of this, we call it the nerve vital, the life knot. And in fact, already in the 1800s, Florent, based on simple experiments in lesion experiments, provided evidence that in fact the medulla is essential for survival. And this area is the one. And as you can imagine, if this area stops, you get oxygen deprivation and you get a brain damage. However, it's important to understand that it's not only a coordination between the brain and the lungs that are sufficient to provide enough oxygen. In fact, you have to coordinate the brain, the breathing, and the heart. And we've heard already about the importance of the heart in the previous talks and the importance of the lungs in the previous talks. So all of this has to work together in order to provide enough oxygen to the organism. And functionally, they're also overlapping. So each time you take a breath, your heart rate goes up. And then when you exhale, the heart rate goes down. This is the sinus arrhythmia. And it's a sign of a very good coupling between the brain and the heart. It's this heart rate variability that is actually a good thing. There are many themes to this coupling. When you take a breath hold, so you hold your breath, your heart rate goes down. It is a way to save metabolic energy, and you're going into a hypometabolic state in many of your organs, and now focus the blood supply to the brain in order to keep it awake and avoid any damage. So it's a whole body response involving all organs that is coordinated with the breathing. Now, this breath holds or the diving response are disturbed in many diseases, and one of them is Rett syndrome. So this is a child that suffers from Rett syndrome, and she has heavy breathing, and she goes into a breath hold that takes a long time. And during this breath hold, you don't have a normal diving response. You have an abnormal response. So initially, as the child goes into breath hold, the heart rate goes down, which you would expect, but then you can see the heart rate escapes and stays up even though breathing resumes. So there's an uncoupling between the breathing and the heart. And this situation now basically causes hypoxia. And the problem is that this child is not only generating one of those breath holds, this is one breath hold, but when she's awake, and this is typical for Rett syndrome children, they have these recurrent apneas, these recurrent breath holds. And during each of them, they generate intermittent hypoxia. So you have an intermittent hypoxia. And this intermittent hypoxia is a characteristic feature, not only for Rett syndrome, you find it in familial dysautonomia, when you have this sudden desaturation. You find it in obstructive sleep apnea, where you have this recurrent intermittent hypoxia due to an obstruction of the airways. You have epilepsy, which also can happen several times a night, where each time there's a seizure and leading to intermittent hypoxia. The consequences of intermittent hypoxia is that heart rate is increased. This is from the Rett syndrome patients we looked at, and heart rate variability is reduced compared to the controls. So a characteristic feature of dysautonomia, increased heart rate, decreased heart rate variability. This is just another example from familial dysautonomia. This is the heart rate variability in controls during the day and the night in red here. This is from the patients with familial dysautonomia. You can see during the day and at night, their heart rate variability is reduced. In this graph, each line here is one child. The more red is the higher. So you see the heart rate on average is increased in these children compared to the control. And also, by the way, the breathing rate. In all these cases of dysautonomia, we have also sudden death. Familial dysautonomia, many of these children die early. We have mitochondrial diseases, which is also dysautonomia, where children die early. And then Rett syndrome, you have sudden death. And then there's sudden death of epilepsy. And then, of course, also in severe obstructive sleep apnea. So the question is, what are the mechanisms that couple the heart and the breathing? And this brings us back to this nerve vital, the Pre-Bötzinger complex. Now, this nerve vital, the Pre-Bötzinger complex, you can take out of an animal, put it in a dish, and then remarkably, this piece of tissue starts to breathe. And it's just a piece of isolated tissue. In this case, this tissue doesn't have much oxygen. And so you get very slow activity, like now comes one of these respiratory activities, which is a gasp. There's not oxygen. Then you provide oxygen, and then you can see the breathing resumes, and at a higher frequency. And now you take away oxygen again, and then you can see this goes into the gasping mode again. And then you bring oxygen, and then the breathing comes back. So now you have to remember that this is just a piece of tissue, very, very small tissue that generates the respiratory activity in vitro. And this piece of tissue actually controls the cardiovagal neurons. So each time there is an inspiration, the cardiovagal neurons are inhibited. And because the cardiovagal neurons are inhibited, the heart rate goes up because the cardiovagal neurons are inhibiting the heart. So basically, in this area, you have a very close connection between the Pre-Bötzinger complex, which sits here, and the cardiovagal neurons, which are sitting right beside each other and are inhibited. And so how do we know that this connection is important? And we know this because we can optogenetically manipulate these cardiovagal neurons and activate them with light. And when we activate them with light, then you can see the effect. So this is the cardiogram from an intact mouse, phrenic nerve activity. Each line is an inspiration. So now we activate these cardiovagal neurons at the Pre-Bötzinger complex, and you can see this dramatic decrease in the heart rate. And then when you stop the stimulation, it comes back. So showing that this area is really important for controlling it. Now, we also know that these neurons, as I showed you, are inhibited during each inspiration, which then translates into a heart rate increase. So basically, here we have this coupling right at the central nervous system. So we can now ask the question, what happens to these neurons in hypoxia? And what happens is you get an upregulation of HIF1 alpha, the hypoxia-inducible factor, which then also is accompanied by the release of reactive oxygen species, which is kind of surprising. But when you expose these neurons, the cardiovagal neurons, but also the Kribotzinger neurons, and expose them to hypoxia, you start to produce hydrogen peroxide. And then especially when you go back, you get also a burst of hydrogen peroxide. So after like several days of this intermittent hypoxia, you see signs of lipid peroxidation, signs of reactive oxygen species within that very center. So basically hypoxia is causing both an hypoxic stress, but also an oxidative stress. And you see the same thing in Rett syndromes. This is data from Rett syndrome children from Ciaccio in Italy. They show also an increased lipid peroxidation like in our model that is associated with this intermittent hypoxia that these children suffer from. Now, so what is reactive oxygen species doing to this network? And what it does is it inhibits these cardiovagal neurons. So normally they are active and then inhibited during an inspiration. Now they become inactive, which means there's a disinhibition of the heart rate goes up. There's also a loss of the heart rate variability because these neurons are just hyperpolarized, then they don't show anymore this modulation. And this could translate, or it's definitely one contributing factor to the same things that we see an increased heart rate in the patients. Chronic intermittent hypoxia also alters the Perfusion complex itself, the network. So here is the Perfusion complex, here are the cardiovagal neurons. So it affects directly this center by decreasing excitability. So the neurons are much less excitable after chronic intermittent hypoxia. And because they're less excitable, they don't synchronize very well during each breath. So you get failures of synchronization. And so you get amplitude fluctuations in the population activity in this Perfusion complex. So here, after chronic intermittent hypoxia, you get these amplitude fluctuations. And these amplitude fluctuations are actually important because they drive the hypoglossus. So the Perfusion complex is driving the tongue. And each time you take a breath, your tongue gets activated to open up your upper airways and allow airflow coming in. Now, if this drive to the hypoglossus is disturbed, you get an obstruction, and then basically the airflow is obstructed. Now, this is the connection. Here's the Perfusion complex. Immediately here's the hypoglossus. And each time the Perfusion complex is activated, it drives the hypoglossus. After chronic intermittent hypoxia, what's happening is, because of these fluctuation in synchronization, the hypoglossus doesn't get enough drive, and you create a hypoglossus apnea, which causes a mismatch with the diaphragm and an obstructive apnea. So basically, the intermittent hypoxia is causing these hypoglossus apneas that then drive, of course, intermittent hypoxia. Now, you can rescue this effect of chronic intermittent hypoxia by giving these animals reactive oxygen species scavengers like MNT and PYP for several days, and then you normalize it, suggesting that indeed what's driving this uncoupling is reactive oxygen species. So it's not the hypoxia, it's the ROS that is produced by the intermittent hypoxia. Now, what I showed you so far was that the central nervous system controlling breathing, controlling cardiorespiratory coupling, and controlling the upper airways are sitting all very close by, and they're all very sensitive to intermittent hypoxia. And they basically respond to intermittent hypoxia by the production of ROS, which then uncouples these networks, uncouples the cardiovascular vagal neurons, uncouples the drive to the hypoglossus due to this ROS. So the question is, why oxidative stress? And I think we heard this in the previous talk already. And it really is due to the balance between HIF1 alpha and HIF2 alpha. And this is pretty timely because in 2019, Greg Semenza received the Nobel Prize in medicine for the discovery of HIF1 alpha. And the HIF1 alpha is the pro-oxidant. It activates all the hypoxia genes. It causes a lot of reconfiguration in your body. But the brain also, and the body also contains HIF2, which really is the antioxidant system. And that was done in collaboration with Nanduri Prabhakar. So Greg Semenza and Nanduri Prabhakar established the importance of this balance between HIF1 alpha and HIF2, which brings me to the good side of hypoxia, because under chronic hypoxia, what we've heard in the previous talk, you actually cause a balance between HIF1 alpha and HIF2. So you cause a balance between the pro-oxidants and the antioxidants, and that confers adaptation. Now, in chronic intermittent hypoxia, there's no time for the buildup of HIF2 alpha, but there's time for HIF1 alpha. So you cause an imbalance. The reactive oxygen species will then causes damage not due to hypoxia, but due to the oxidative stress. The principle that I discussed now for the ROS production in response to intermittent hypoxia, I think has general implication, not only by intermittent hypoxia, but by other stimulants that cause an imbalance, like air pollutants, heavy metals, biotic stress. All of these factors cause an reactive oxygen species and cause a disturbance in this control of your autonomic system. And just to give you an example, this is from our own clinic at Seattle Children's. My colleague, Dr. Mark Wainwright, was monitoring a critically ill sepsis patient. And this is the time. You can see here the heart rate variability, very large heart rate variability. And then at 6 a.m., this patient suffers from cardiac arrest. And then the next day at 6 a.m., the patient expired. It's a child. But what you can notice is that 12 hours before the cardiac arrest, there's a sudden drop in the heart rate variability that kind of preceded the cardiac arrest and gave us an indication that there is a dysautonomia happening. And this is very anecdotal evidence from the internet, from someone who posted their heart rate variability after the infection of COVID. And again, you can see this dramatic drop in heart rate variability that was associated with this infection. So we know that COVID, the virus SARS-CoV-2, binds to ACE2 receptors, the enzyme, angiotensin converting enzyme 2. And ACE2 plays a big role in this balance that we just talked about, the balance between oxidative stress and the antioxidant system that is conferred by angiotensin 2 and angiotensin. And so if the virus attacks this enzyme, you're shifting this balance towards inflammation, fibrosis, as we heard, oxidative stress, vasoconstriction, cell proliferation. That was all discussed in the first talk in the lungs. So this is the response which affects the lungs, as we heard, but it also affects the brain, because the brain contains ACE2 receptors in the critical areas that control the cardiovascular system. And but in addition, the brain is also indirectly affected by an inflammation. So if you have lung inflammation, as we heard in the previous talk, in the first talk by Paulo, within a few minutes after the inflammation, you get upregulation of inflammatory receptors like TLR4 that via the vagus nerve go into the Perfusion complex. So within a few minutes after inflammation, you get upregulation of microglia, and you get an inflammatory response in the central nervous system and the production of reactive oxygen species, as we heard also in the previous talk. Moving forward, we're engaged in a collaboration with our pathologists, Dirk Keen, Desiree Marshall, and Amber Nolan. And we want to look at patients with COVID-2. And we started to stain for ACE2 receptors. So here is from a human patient, the ACE2 receptor in green. So these are all these neurons that contain COV2, they contain ACE2 receptors. And we want to now see how it is on average changed in these patients. We are also using staining for microglia to characterize the inflammatory response. And we want to identify specifically the Perfusion complex. So this is from a human patient. This is the nucleus ambiguus, which contains the cardiovagal neurons. This is the hypoglossus that I talked about, the upper airway. And this is the Perfusion complex. And now having basically this histology will allow us to see whether in COVID patients or in a subset of patients, there was an inflammatory response. I don't have data yet because it is a huge process, regulatory process, to be able to get access to these patients. And we got this access, but we're working on it as we speak. So I really want to thank my lab. I have a lot of very, very talented postdocs and graduate students. Here's Gia from Peru. She is a pulmonologist and worked on high altitude. She's working on patient data right now. And we have experts for human translation, etc. And here's Greg Semansa together with Nanduri Prabhakar and his wife, Jay Nanduri. And here we're celebrating the Nobel Prize because we have a grant together, working together on the effects of intermittent hypoxia. But I don't want to end without thanking again Dr. Biradar. As I mentioned at the beginning, I'm really grateful for his leadership and for the honor to get to know such an incredibly humbled yet knowledgeable person. And again, I want to finish with a sentence here which says, grief and gratitude are kindred souls, each pointing to the beauty of what is transient and given to us by grace. And here we see this moment here when he gave me the flowers by grace. And it was a transient event, but the gratitude persists. So thank you very much, Dr. Biradar, for your incredible influence on all of us. And thank you everybody for listening to this talk, and which is now kind of open for questions. Thank you so much.
Thank you very much, Nino, for excellent speech, excellent deliberation, and remembering.
Kushal, I don't hear you for some reason.
Hello.
Dr. Oh, no. Yeah, I hear you.
Yeah, are you hearing? Yeah. Thank you very much, Nino, for excellent deliberations and remembering Professor Dr. M.S. Biradar, who is the mentor of all of us, and your association, though it was a less period and time concerned, but it was so deep rooted in via internet, mail, exchange and all, that to be always remembered. And we are thankful to you, myself and Professor Gustavo, you will be speaking now, and to accept our invitation to be with us at BLD deemed to be University and IPPA Zubieta University La Paz together. And we hope that in future we'll follow the pathways of Professor M.S. Biradar and go for the collaboration in a multidisciplinary ways in the different parts. That to be actually the purpose. We have started, but COVID has reduced, but we'll again go ahead after the COVID. So thank you very much. Now I will over to Dr. Sanjeev, Dr. Baradal. Dr. Baradal?
Yes, sir.
Yeah, now you have a privilege to ask one questions to him, and last one question from one young faculty member. Young faculty member, be ready. There'll be no time. Only one question. Yeah, over to Bashavraj Baradal.
Professor, just in my clinical practice, what I observed, what you told about hypoxia, variability of heart rate, wherever patient comes with any RT or any head injury or any raised ICT, those who presented with tachycardia more than 130, 140, they couldn't revive. This explains everything about what you explained about the pre-Buchinger complex and hypoxia and the reversibility. Very informative speech, sir. Thank you very much for this one. Thank you.
Thank you very
Thank you
much.
very much.
Dr. Raj. Thank you.
Thank you very much for sharing your experience. And I often give grand rounds to our neurosurgeons, and we exchange a lot of ideas because, you know, how can we prevent this tachycardia? How can we prevent, you know, the uncoupling? And as I said, I think lessons are learned, and we have to not battle the hypoxia. We have to battle the reactive oxygen species in these situations. So thank you so much.
Thank you, Nino. Thank you, Dr. Bashavraj. One question from young scientist group, young faculty member. Please, anyone?
Great talk, Nino.
Thank you, young faculty member.
Any young faculty member? Anyone? Any question from young faculty? Okay. So okay. I think that there is no question from anybody. So it is good for us also. And because many people will be feeling that they have asked the questions and I have not given them chances. So it is one way good. So I think that I must conclude this session now. I request and first to our IT department, Mr. Anand.
Sir.
Yeah, be ready with the certificate of honors. I request Dr. Bashavraj to confer certificate of honors to Professor John Marino Ramirez of University of Washington, Professor of Neurological Surgery.
Sir, here I'm conferring.
Thank you, Nino, for accepting.
Thank you very much. Thank you very much. It's a great honor. Thank you so much.
Thank you, Nino. Thank you very much. And thanks to Erika also. She is also here. And by the way, that Nino's wife, spouse, Dr. Erika herself is a biologist. So I think that now the time has come. So I request Anand, please put up the certificate of Dr. Bashavraj Bardal. On behalf of Dr. Nino Ramirez and all the guests here, Yale University and IPPA together confers the certificate of recognitions to Dr. Bashavraj Bardal.
Thank you, sir.
Thank you. So thank you very much. Now the last, but not the least, the speaker is the charismatic Professor Gustavo Zubieta. So for him, I think introduction is a no introduction. So that will be given by the chairperson. I will introduce the chairperson to you. The chairperson of this session is Dr. S.S. Kallana Shettar. He is the professor and head Department of Pediatrics, CBM Patil Medical College, BL University. He did his MBBS from Alamin Medical College, Bijapur, MD from Dr. BM Medical College, Sholapur. She secured the first in the rank holder. He's a gold medalist and first rank holder. And he has a research and academic interest like a pediatric nutrition is interest, intensive care and infectious disease also his research interest. Over to Dr. S.S. Kallan Shettar, Professor of Pediatrics.
Thank you very much, Das sir, being my teacher from my undergraduate days. Thanks for the kind introduction. It's my privilege and honor I feel to introduce before you Professor Gustavo.
मैं एक लेक्चर में थोड़ी देर में बात करूंगा आपसे मैं.
Professor Gustavo Zubieta Calaha is a well-known personality in the field of high-altitude hypoxia. He is the director of High-Altitude Pulmonology and Pathology Institute, Zubieta University, La Paz, Bolivia. He is the professor in charge of pulmonology, bioengineering, and computer programming at IPPA. Sir is also a visiting professor at University of Copenhagen, Denmark, and our own BLD deemed to be university. Sir is an editor of many prestigious journals like High Altitude Medicine and Biology, editorial advisor of Wilderness and Environmental Medicine, Acta Physiologica, Indian Journal of Chemical Biochemistry, and BLD University Journal of Health Sciences. Being a stalwart in the field of hypoxia, Professor Gustavo has many innovations to his credit. He developed and constructed a computerized hyperoxic and hypoxic adaptation chamber and Chakaltaya High Altitude Pyramid Laboratory located at an altitude of 5,300 meters. His further contribution is to modify the Vance-like acid-base balance high altitude equation. Along with his mentors, Professor Paulo at Copenhagen and his illustrious father, Professor Gustavo Zubieta Castillo, he has created high altitude diving tables. His invention of tolerance to hypoxic formula and concept of space travel in a chronic hypoxic environment, creating the term biospace forming, is recently being acknowledged at Space Physiology Symposium in the Pan American Physiology Congress at Biradar, Cuba in the year 2019. An excellent orator, Professor Gustavo has given invited faculty lectures at NIH, Tulane Medical School, Center for Space and Planetary Sciences at University of Arkansas, Geriatric Society in Pennsylvania, and DRDO of Government of India. Recently, during this current pandemic of COVID-19, Professor Gustavo has proposed a new hypothesis for lung injury in COVID-19, that is pneumolysis, and is widely being acclaimed. Last but not the least, Sir is a celebrity himself. His life and works are shown in Discovery Channel. So today, Sir will be talking on high altitude hypoxia research applied to COVID-19, seeing the light. So thank you very much, sir, for joining. So over to you, sir, for the talk.
Thank you very much, Raghu. I love that introduction so much. Can you please repeat it? Just kidding.
It will be my pleasure, sir.
Thank you so much. You have been very generous with me. Three truly outstanding speakers were ahead of me. And that's tough. I was not the first in these talks. I should have been, so I would be more relaxed. I was put last. So it's hard to keep up to their level. But let me tell you one thing.
But you are the host. You are one of the hosts.
Yes. But let me tell you one thing. I have an advantage over them, okay? Yes. This is one of my beautiful prizes from India. First of all, I want to express my love for India and my great respect for Professor Biradar, of course. I feel deeply happy, and I know he's happy somewhere, listening to these talks, because it's in his honor. He deserved the best. And here I have been able to bring three of the best and one along. So here goes my talk. I am sharing now my screen. Okay. Are you able to see it? Yes?
Yes.
Okay.
Go ahead.
So my talk here is termed High Altitude Research Applied to COVID. Very interesting stuff. But also, look at this. Seeing the light. So I hope you see the light the way we have seen it here in La Paz. So here's the MS Biradar Memorial Lectures. And if you see a patient like this, you show it to any pulmonologist practically all over the world. Look at these lungs. This is the chest X-ray from CAT scans. Look at these lesions, both sides. Look at the saturation with oxygen, Look at the heart rate. We measured the D-dimer, 2,900. Wow. The C protein, 6.8. Diagnosis, please. I know what most would say. But 2 days later, look at the lungs. The CAT scan. 3 days later, saturation on 2 liters per minute by nose prongs is 99. Breathing ambient air in the city of La Paz, where this presented, 91. What is this? This is totally normal saturation in the city of La Paz. Okay, so the diagnosis is high altitude pulmonary edema. No pneumolysis, and that's the huge difference. But the hypoxia is so similar, so similar. That is why we have seen the light in COVID from a different point of view as high altitude specialists. You see, this is our city of La Paz. Our normal saturations are between 88 and 92 at 3,500 meters. Of more than 2 million people going around perfect normal lives. We live in silent hypoxemia, as my daughter has Dr. Natalia Subieta has very well pointed out. We live in silent hypoxemia, completely silent. And I should add happy also, very happy. What is the most important factor of lethality in COVID? Obviously, it is hypoxia. What is the oxygen capture organ in the body? The lungs. The lungs. What a beautiful organ. What a specialized cells, thin respiratory cells called the alveoli. You will see some more later on. Are other organs involved? Yes. That's why we described, not why, but we described previously the oxygen transport triad. Actually, that's an idea originated by my father, Professor Dr. Gustavo Subieta Castillo, who is no longer with us since over 5 years ago. But it has to do with 3 fundamental things. The pneumodynamic pump, which are the lungs, the hemodynamic pump, which is the heart and the cardiovascular system, and hemoglobin. These 3 things allow for the transport of oxygen from the environment all the way to the tissues. So what happens? The pneumodynamic pump, when it gets hit by COVID, suffers pneumolysis. And Professor Paulo Pelosi has given us a wonderful talk about that aspect of the necrosis. That's why it's pneumolysis. And he prefers to add also pneumovascular lysis. And you will observe here that the hemodynamic pump can also be compromised. And you can see that it can produce myocarditis in COVID. But also, a very important thing, vasculitis. And I have seen patients, I don't have it right now with me, but I have seen patients that have presented a tongue like Kawasaki syndrome of vasculitis in these COVID patients. Very interesting. That we're going to publish that with Paulo in a forthcoming paper. But the third factor of the oxygen transport triad is hemoglobin. Hemoglobin down here for us is the protection factor. It is the life-sustaining factor. It is the miracle molecule, hemoglobin. Do you realize that iron is the most stable element in the planet? That most stable element in the planet where fusion and fission divides in all the elements is in our red blood cells. Why? Because oxygen is the primordial element of life, along with water and all the other components. But oxygen is the more time-critical element of life. So look at one of our recent publications with Dr. Virue Soto and several of our colleagues. Jorge Solis is there also, Cristian Arias Reyes, Dr. Natalia Subieta, of course, Merino, and all our colleagues here. You see the level of EPO was measured and hemoglobin in patients entering with COVID case at the hospital. And then Dr. Virue Soto and Dr. Merino and Dr. Tinoco, they all checked when the patients were either discharged or died. And look at the difference here. You see EPO, those that had high EPO were the survivors in white. Those that had low EPO died. Isn't that interesting? And look at hemoglobin, same thing. Those that high hemoglobin survived, and those with low hemoglobin did not survive. Hemoglobin is the saving factor. That's why we have been always proposing that we should use erythropoietin in COVID patients. We have used it, and it has given us wonderful results because of the oxygen transport triad. Now, why did we come up with all these ideas? Because we have observed many things. For instance, we presented this in Brazil at the Pan American Physiology Conference. You see, if you're at sea level and you have a PaO2 of 100, how much hypoxia can you tolerate? Where is hypoxia best tolerated? At the sea level or at the summit of Mount Everest? Well, it's at the summit of Mount Everest. The PaO2 taken in our arterial blood samples is 24 millimeters of mercury at the summit of Mount Everest. And these guys are breathing without oxygen at the summit of Mount Everest, and they don't die, except for other factors. So obviously, there is a paradox here. The higher you go to high altitude, the more tolerance you have to hypoxia. And this is, you see at sea level, it's close to 1, and at Mount Everest, it's close to 6 times more tolerant to hypoxia. Magnificent advantage of chronic hypoxia. However, it has to be with hemoglobin, with a higher hemoglobin. So that's why we created this formula, the tolerance to hypoxia formula, okay? And this formula has the hemoglobin on top. More hemoglobin, more tolerance to hypoxia, no doubt. Lower carbon dioxide, which happens at high altitude, more tolerance to hypoxia. Carbon dioxide is essential. It is the balancing factor of tolerance to hypoxia, and critical, may I say. So, you know, one of the studies also is how hemoglobin increases when a person going from sea level goes up to the highlands. And in this case, it was me. You see, I went 3 months to Copenhagen, worked with Paulo, and I had lowered my hematocrit to 36. Now, normally in La Paz, it's 50%. It's been like that all my life. My father's hematocrit was 50% all through until he passed away at 90 years of age. And so how did I recover? I ran tests on myself, and this is the way I recovered my hemoglobin from 36 to 50% in 40 days. It took 40 days to go up. 50% of the recovery was done in 1 week, but still we get a little tired going upstairs and so on. So there's an intermediate adaptation, and there's a full adaptation of normal life at high altitude. So you see, you need time to build red blood cells. So the high altitude inhabitant has an advantage, and that's a great tolerance to hypoxia, which makes the opposite. The sea level inhabitant have a poor tolerance to hypoxia. Why? Because their CO2 is higher than ours. Our PaCO2 here in La Paz is 30. At sea level, you have 40. That's a high level. And remember the tolerance to hypoxia formula. Your hemoglobin is lower than our hemoglobin, so you have less tolerance to hypoxia. And of course, you have more oxygen. That's interesting. But the high altitude inhabitant, due to his permanent exposition to chronic hypoxia, is provided by biological mechanisms of survival that result favorable in multiple diseases and even in COVID-19. Now, let me tell you, I had all these ideas about chronic hypoxia when we were working, thanks to my father, and we have been working with Natalia. And in January 31st in 2020, I was called by Jacqueline Baziga. She's a very notable literarian, and she called me up and said, Dr. Zubieta, we want an interview with you regarding COVID. And I said, well, I don't know much. This is January 2020. COVID had not arrived to La Paz, to Bolivia. And so I said, I'm sorry, I don't think I can help very much. And I hang up the phone. 5 minutes later, they called me again and they said, Dr. Subieta, you have to speak to us about this. And I said, well, okay. So I went and I gave an interview to Johnny Villasuel, and it's online. And there I say, well, at high altitude, we have many advantages. It is highly probable that we will have less COVID at high altitude. And I talked about some other measures I cannot mention right now. So I wrote an article in Spanish, The Advantages of High Altitude and Control of COVID-19 on April the 5th, 2020. As far as I know, I am the first to have proposed this crazy idea. And you see, why was this born? Here is the ultraviolet index in winter in La Paz on top, and in the bottom in Copenhagen, where I was a visiting professor then. As you can see that throughout the whole months, the highest ultraviolet radiation was around 6 in Copenhagen, whereas in La Paz, we didn't even reach that low level. We were above 8 and we went up to 16, 17, 18, amazing levels. So the condor of the Andes, that beautiful bird that flies so high that is quite heavy, and he's flying at 6,500 meters. He has this beautiful vision like all these animals, like the eagle and all that. Beautiful, extraordinary vision to see things far away. And we used his eyes to look at COVID from the high altitude point of view, you see? And so we published this paper. Incidentally, this is with with Natalia Subieta, my great collaborator, and Tupil Venkatesh and Kushal Das and Jorge Solis. And this paper we talked about, this was a preprint on May the 5th, and we talked about several things. It was later published in a journal. The multiple diseases that were involved. We have already talked about vasculitis and all that. Lower incidence of COVID at high altitude. And I'll show you some more of that. COVID-2 virus can float in the environment as it is 120 nanometers and has spikes. That has been proved now. There was a scarce need of ventilators. Paulo showed us how you can use the ventilators efficiently in such a complex disease. The oxygen transport triad was mentioned there. Post-COVID increase in hematocrit, hemoglobin, and red blood cells. You know, when I wrote a paper and I said this would happen, I was questioned by the reviewers and said, you cannot say that. Well, I did say it, and now it's being confirmed more and more. I see the patients that have had COVID here are ending up with a higher hematocrit. It is a low normal compensation factor. And the use of aspirin, very important. Can't talk much right now because of time constraints. Here is the beginning of the pandemic when it arrived in March here in Bolivia. And you see the green line is the lowlands. These two lines, the green and the blue line, is in the lowland cities in Bolivia. And the dotted line is La Paz, the high altitude cities. We didn't get any COVID in the beginning, but then things changed. It evolved. And this is La Paz here, but still we did not reach the levels of the lowlands, even though we have very similar populations. So we sent a letter to the editor, to the High Altitude Medicine and Biology, with the title, COVID-19 patients in the high altitudes of Bolivia and Peru manifest a substantive decrease in mortality. Here are our co-authors. And you can see here, in green, the levels of case fatality in the lowlands below 1,500 meters was 8.6, whereas in the highlands in Bolivia, it was 3.2, almost a third less, the case fatality rate. And Peru, the same. It was almost 6 in the lowlands and 3, almost half lower in the highlands. But many people question and say, no, the UBC doesn't arrive and you can't sterilize. No, but UVB does play a role in sterilization. It's 70% of sterilization efficiency from UVB, which does arrive to the surface of the Earth. And look what happened here in La Paz. While we had high levels of ultraviolet radiation in the beginning, very few cases until we reached 7 of ultraviolet index, and then it shot up, as I have shown, but not to the levels of sea level lowlands. Look at the erythermal ultraviolet index here in October in the world. And you can see that the pink lines are the high levels of ultraviolet index that is shown in the Andes here, in some areas in Africa, and of course in Asia. No? So what happens now in July? It moves up to the top. Now, this means that the protection would move further up north in July. We are in July. And as you can see, the incidence of many cases of COVID, all in these northern areas, has decreased now. But that's not the subject of my talk. Because what happens here in December in South America, and particularly in Bolivia, look at Bolivia and Peru here, you see it's completely in the white scale. We have the highest ultraviolet radiation. Is it bad for us? Actually, it's great for us. In COVID times, of course, and in general. These are the levels of the airport of La Paz, which reached in 2020 close to 6, the lowest level of ultraviolet index. And one of the papers with Christian Arias Reyes and Jorge Solis, Natalia, and several other Bolivians, and Matthias Dutschmann from Australia, that is called, Does the Pathogenesis of SARS-CoV-2 Virus Decrease at High Altitude? It has received so many citations, it's unbelievable, because it touches a very important point, and particularly Jorge Solis and Christian Arias touch the lower quantity of ACE2 receptors from adaptation to high altitude in animals, and kind of parallel that what could happen to high altitude residents as one of the factors. But ultraviolet radiation was also mentioned there because that was my role in that paper. The decreased incidence, virus transmission capacity and severity was also proved by Christian Arias and the whole team. And you can see here from that paper that above 1,000 meters, we have much less incidence of COVID-19, and you see a decreasing incidence with time. But look at this, that I want to thank Roberto Vera, who is a physicist who lives in Potosi at 4,100 meters at the university there. And he observed here, this is the ultraviolet index in the black lines, and in the red lines, you have the COVID cases. Look what happened on January the 7th. We had a decrease of ultraviolet. It was cloudy and all that. What happened 2 weeks later? This is in January 2021. 2 weeks later, we had an increase, as you can see, of the red line of COVID cases. There was an increase 2 weeks later. But what happened also, if we move down to the lowest point, to the highest point, ultraviolet rays, very sunny, beautiful day in Potosi, well, we had the lowest cases. And this we're beginning to observe more and more, and we are getting some more information. So that really makes us happy that I had proposed that ultraviolet radiation does have a protection factor. And look what I did here, this is being published. I took on November the 8th, 128 countries, and I took the average ultraviolet radiation in every country and compared it with the cases of the population per 100,000. Look at the tendency as you go up in the average ultraviolet radiation, the tendency definitely goes down. So I am a strong believer. Some people may not believe it's so. There may be other factors, confounding factors, but there is something very strong here. Now look, ultraviolet radiation creates the photoelectric effect in metals, as you know. Einstein's work, the beautiful work of the two gold platelets, that when you shined a blue light, not the other colors of lights, but a blue light particularly, in that spectrum, it was able to change the electrons and produce a change in the presence of electrons, and this is called the photoelectric affecting metals. Well, I have called the photoelectric biologic effect on life the other side of the spectrum, which is on the life and the biology of beings, living beings. What does this mean? Well, this works on plants producing photosynthesis, and it produces oxygen from carbon dioxide in the environment and the hydrocarbons and so on. It also produces in animals and humans an effect, and also on bacteria, viruses, and fungi, of course. This effect on animals and humans, and particularly in humans, has been the production of vitamin D, which produces stronger bones. At high altitude, we don't have rickets disease. We don't see it. In Copenhagen, I used to see many patients, even in the streets, with rickets disease. So the lack of oxygen in Copenhagen was a factor. Here we strengthen our bones thanks to ultraviolet radiation. And by the way, this also plays a role in immunity, boosts immunity. This is absolutely true. I came to that conclusion because the llamas, the alpacas and the vicuñas have the nanobodies. And this was by a friend Pillay from South Africa that mentioned this to me. So, you know, our immune systems are very strong. And there's a paper now from Tucumán has observed that there's higher immunity in highlanders. Very interesting. So all these three factors, you know, the immunity boost becomes a protective factor against COVID, the viruses. And at high altitude, it's a stronger protective factor because of the conditions of the environment. We have probably a higher immunity boost. We have stronger bones, of course, and confirmed high altitude case fatality rate due to COVID. This is a recent study that Natalia and I have been the leaders of a multinational study of Bolivia, Colombia, Ecuador, Peru, and Mexico. So we have studied 161 million people and how they presented COVID and their case fatality rates. These are all the co-authors. Well, of course, there are many. And what we have seen in Bolivia, you see the black pie charts here. This is the below 1,000 meters of altitude, and this is above 2,500 meters. And you can see the rates are much lower in Bolivia, Colombia, Ecuador, Mexico, and Peru. It's confirmed. For me, there is no doubt. Many may talk about confounding factors, but it's a fact. At sea level, an SpO2 of 90% induces ventilator use as one of the factors, along with tachypnea and all that. But whereas in the city of La Paz, we live with SpO2 of 90%, a PaO2 of 60, that's normal. That's normoxia for us. But this new terminology that I've called pneumolysis, it's pneumolysis in Spanish. It has to do with the idea of destruction of the lung by the virus. And let me add that this destruction is an aggressive viral, tremendous, extreme viral aggression to the lungs with destruction. And what does that produce? Well, it sort of puts a man at sea level with this destruction of the lungs, suddenly in short time at the summit of Mount Everest, but with not enough hemoglobin, with too much carbon dioxide. And so the tolerance to hypoxia becomes very low, and it's very critical. And this, of course, gives rise to the end of life, unfortunately. So look at this other case of a high altitude pulmonary edema that I treated at 3,510 meters. We treated it at our institute. This is the CAT scans. You see the lungs. Look at the saturation when he arrived, walking into our clinic in, this is several years back, 54% saturation and 107 pulse rate. This was the next day during part of the treatment without oxygen in the environment. So you see how low those values were? Look at the evolution of the chest x-rays. The lungs in another case was when the PaO2 was 30, they were filled with cotton-like images. But look 2 days later, particularly in young people, it's completely clear. And it returns to the normal arterial oxygen tension. In COVID, the lesions begin to advance. It's highly, the virus, the people cough and start spreading the lung disease, attacking more and more alveoli throughout the lungs. And so the virus goes into the lungs it links to the ACE2 receptors as shown here, and they come in to the cells and they reproduce themselves within these beautiful cells that are the alveolar cells, a very beautiful specialized thin membrane where oxygen can go through and carbon dioxide can come out. But then they destroy the cell, they block. By the way, this produces the necrosis that Paulo talks and is proving. It also produces, as well as described, of course, the shunt effect, because if the alveoli are destroyed and there's some more circulation still going on, it's a shunt effect. There's ventilation perfusion anomalies, obviously, as he has shown, and also diffusion anomalies, because the thickening and the inflammation reduce the oxygen going through. And of course, these go, once the cells break, the coughing, and it spreads to the rest of the lung. That's why it's so aggressive. And it pulls, of course, vasodilates, but it also goes in this destruction within the same capillaries. Now, this produces vasculitis, and it varies, of course. Not all cases are similar. To show you the physiopathology of the silent hypoxemia, here you can see that at sea level, the oxygen is at 100, and these are normal chest lungs. And as it progresses, the oxygen goes down. But you can see that there's no minor changes initially between pH, PaCO2, and ventilation. Ventilation increases very slowly, and that's why there's silent hypoxemia, even for us residents at high altitude. But this evolution grows and the saturation begins to drop. The PaO2 drops tremendously with time. And at a certain point, it begins to feel lack of breathing. Very important. Now, during this phase, what happens is that they are climbing to the summit of Mount Everest. It's this very similar phenomenon. Most high altitude experts at sea level, high altitude sea level experts, have said, no, this has nothing to do with high altitude pulmonary edema. Well, I have to contradict them. I'm sorry. But this is very similar physiopathologically to what happens with high altitude pulmonary edema, not anatomically, not in destruction. There's no pneumolysis in high altitude pulmonary edema. So what happens at high altitude? We start with a PaO2 of 60, which is lower than the sea level PaO2, and our carbon dioxide is also lower. So we have a lower increase, a lower slope of the decrease of oxygen. And it's an advantage because we are handling it better. Now, of course, we have published some papers like pneumolysis and silent hypoxemia. So what happened in this pandemic? Look at the balance. What's worth more? People have been running around looking for oxygen in many cities of the world. Oxygen became more valuable than gold because life is given to you by oxygen, not by gold. Very important concept. The hemodynamic adaptation, the high altitude adaptation formula that we described is shown here. Adaptation is equal to time over altitude. I won't discuss much of this because of the time frame, but one of our last recent papers that was published is called Acute Mountain Sickness, High Altitude Pulmonary Edema and High Altitude Cerebral Edema, a view from the high Andes with my daughter, Natalia. And this was published in volume 287 of Respiratory Physiology and Neurobiology. We received many letters of many people and also great scientists that really enjoy this paper. But you know what happened? Many sea-level high-altitude experts don't believe what we are talking about because they are in the lowlands. We are up here. And so from they wrote to the chief editor to ask that it be retracted. And this traduces what's going on with the concepts of chronic hypoxia that are not fully understood, and acute hypoxia, of course. So it was from different countries, but 76% were from sea level, 2 were from low altitude, 1 was from moderate altitude, only 1 from high altitude, but he didn't have any papers in this area. So you see, that that shows you that there's a poor understanding of hypoxia. And just to give you a little glimpse, here on the left is a tongue of HAPE patient that we saw in 1989. And we have described this as the HAPE tongue. And we have mentioned that there's a strong possibility that it's a virus associated, but it was a type of virus that would fix to the alveolar cells, of course, you know. It would produce inflammation, it would produce the hypertension and so on, pulmonary hypertension and the edema, but not lesion to the alveoli. But look what's so interesting here. The COVID tongue, which is a viral tongue, has this presentation. Now that's very interesting because we have proposed this, and Andrew Pollard published a paper on children and at high altitude, and there he mentioned us that we had talked about a viral theory of HAPE. But recall, it's a different thing. And just to mention, my father in 1964 was working in dogs here in La Paz. Of course, I just learned from František Koller in his beautiful presentation that Alberto Hurtado had actually talked about this in 1960. But at the time, there was no communication practically. We had no journals in La Paz. My father had no journals, had no access to information. And so he independently looked at this function. We published some papers later on. But he affirmed also that the hearts of high altitude residents are much more resistant to hypoxia, the lack of oxygen and sea level residents. František has shown that beautifully. The pyramid laboratory that we have here is one of the, it is the highest in the world because the Chacaltaya Cosmic Physics Laboratory is at 5,200. We're a little higher than they are. And it is the highest in the world. We can go in 2 hours to it. Here we're working with the high altitude divers of the highest diving school in the planet in Lake Titicaca, with the Bolivian Navy, La Armada Boliviana. And they went on to do some diving at Licancabur, the highest diving lagoon on top of the mountain Licancabur. We questioned with Paul-Eric Paulo and my collaborator, my brother Luis, my nephew, who's also a medical doctor, and my father, why do over 200 million of healthy altitude residents really suffer from chronic acid-base disorders? So we don't. We have our own acid-base balance, and we created the variables to come to understand how the acid base behaves at high altitude. Here we are with Paul-Eric Paulo at the University of Copenhagen, and this is Ole Sigurd Andersen. It's a beautiful story. I'll tell you some other time. We have shown that we live longer at high altitude. We have extended longevity. This is going from the lowlands cities of Bolivia to the highest cities. And you see the tendency for greater than 100 years of age is much more at high altitude. That's shown at greater than 90 years of age. Also, look how big the difference is from Santa Cruz at 416 meters with a similar population to La Paz at 3,800 meters. Big difference, more older people at high altitude. And that's why we wrote this paper at BLD University Journal with Natalia. It's very beautiful. And let me tell you that at ABQICOM, at the Association of Clinical Biochemists of India, that I was kindly invited to with Professor Abbas Ali and Tupil Venkatesh. And here is the King George's University Vice Chancellor, one of the top medical schools along with BLD in India. And we are lighting the candle here. And at that event, Vice Chancellor kindly referred to me, "Oh, you are the hypoxia man." That was very interesting. So many are calling me now the hypoxia man, and because of that event. And this, of course, I have to honor always my father, who is the great mountain guru named at St. John's Medical College in Bangalore, 2009. What I have shown you derives from his school, his way of thinking. He was a brilliant man, a true genius, I'd say. I must thank Natalia Subieta, my daughter, my collaborator, Lucrecia de Urioste Limarino, my wife, Rafaela, my other daughter, Lucia Quispe, and many other people that have collaborated with us. And let me tell you that we have no grants here in Bolivia. We have never received a grant to do research. We have done it only because of our love of science. So we appreciate if somebody can help us boost our work. That would be great. For not only, I believe, our work helps the 1.2 billion people in India, it helps the 7 billion people that in all. I want to thank everyone. I hope I have kept up to your expectations. And here I end my conference.
Thank you very much, Professor Gustavo. It was a just amazing story. It was amazing and it's a brilliant also. I think Professor Mulimani sir, our former Vice Chancellor, he wants to tell something. Yes, Professor Mulimani sir. Sir, please.
I am a non-medical person, but it was a very beautiful talk by a magician.
Yes.
And it is extending all over the world. The research extends, that's something. And some researchers asked this paper to be retracted. That has happened with all great works. If we look into the history, and Professor Gustavi is on the way to Nobel, I feel it's a matter of time. It's a beautiful, beautiful talk. Even if you look at a very limited data in Karnataka, in the beginning, we had many cases in Gulbarga and Bidar. Today, if you no cases at all in Bidar, which is at a high altitude. It's a kind of thing, wonderful work. A magician on the way to Nobel in this field when everything is settled, I am sure. Great.
Thank you very much, sir, for.
Thank you. I have to respond, Dr. Kusal.
Yes,
Dr.
please.
I had the honor of meeting you. You were the previous Vice Chancellor, and I enjoyed so beautiful moments with Professor Biradar, Professor Kusal Das at BLDE. I'm very honored, and I think you're very generous in your words with me. You're extremely generous. Thank you.
Thank you very much. And
yes, Gustavo, just a second. Gustavo, I'm Professor Prasad from Lucknow.
Yeah.
Oh, hello, Professor Prasad.
A terrific lecture, I must say. Probably I have listened for the first time your whole lecture. It's terrific and a new idea. I agree.
Yes.
Thank you.
I request now the chairperson to form in a conventional way to ask, privileged to ask the questions to legendary Professor Gustavo Zubieta. Over to chairperson.
Thank you very much, sir. Sir, it was a very illustrious lecture, I can say. I have got one doubt, sir. What is the role of this coenzyme Q10 in tissue hypoxia and its role in therapeutics to COVID-19? Coenzyme Q.
I have not the lightest idea. I think maybe Paulo can answer, or Nino, or all the great biochemists and neuroscientists, because I have no idea, Dr. Zagu.
Sir, I have one more question. Like you explained the UV radiation and its role in this COVID-19 and all, sir. Sir, now many people are trying low radiation therapy in the treatment of COVID-19. So what is its role in improving hypoxia, sir?
Low radiation therapy, low ultraviolet?
No, not
How
ultraviolet.
do they do that?
No, actually,
radiotherapy.
No, I think that you want to say the magnetic.
Oh, radiotherapy.
Yes.
You want to mention the
electromagnetic.
Electromagnetic.
Yes, sir. Yes, sir.
I think the
yes.
I think the low frequency that is completely opposite to UV.
Low frequency.
Completely opposite to the UV.
Yes. And Hamid Mobasheri can probably also.
I think Dr. Hamid Mobasheri is here very much. He's waiting for this once, and I was actually going to call him now for Professor Hamid Mobasheri.
Yes.
Yeah.
But before Hamid speaks, please, I want to answer something. In the meeting that Professor Kusal Das asked me to join, where Hamid was present, at the UNESCO, we had beautiful conferences with the UNESCO team, at the beginning of the COVID, I had mentioned that maybe we could use defibrillation techniques in the COVID patients because a high voltage could maybe kill the virus. Of course, this is has to be managed wisely in a respiratory center, in a therapy center, but nobody has tried that. But maybe that can have a favorable effect, but that's a very high voltage, high ampere, not low ampere, but high voltage, like defibrillating the heart, but it maybe has a sterilizing effect. I just want to mention that before Hamid.
Yeah, Professor Hamid Mubashiri, he is the professor of and director of Institute of Biophysics, University of Tehran, and the Faculty of Medicine. Professor Mubashiri, it's a great honor you are here, and you can have your questions to your great friend, Professor Gustavo Zubieta.
Right, thank you very much indeed, and thank you. And it's my honor to participate in the memorial session of Professor Biradar, who I had some chance to see him during these virtual conferences. I thoroughly enjoyed his humbleness and his courage to somehow promote the collaborative research in the world. And that was very great, very nice of you all to commemorate his nice personality. As for the question about the magnetic low frequency, we are working on the different biophysical effects, biophysical situation on the COVID-19 virus, SARS-CoV-2. As you know, it does have some channels in the membrane. There are rectifiers channels, and it's quite strange that how does a virus need such a channels to rectify the currents. The zeta potential of the virus is rather positive. So that is another point to work on, and we are working to titrate the virus by anions so that we can titrate and lessen the infectivity of the virus. At the same time, we are trying to detect the virus at high frequency, as high as 900 megahertz. And we think that similar to other viruses, it is possible to detect it in minor amount. As for the question with the Professor Zubieta talk, my question is, have you ever checked the virus integrity at higher altitude? We know that the water content of the virus stabilizes the spike structure, and the integrity of the virus that has a membrane. And at high altitude, you have low humidity, you have low oxygen, you have low pressure. That is very important to keep the integrity of the virus. So what if the virus infectivity has been lowered, not because of the physical chemical reaction of the people, but because of the virus itself? Possibly the virus at high altitude is different than the one at sea level. Have you checked that?
Well, we haven't checked because we don't have the technology to check that. It's an interesting point. We do get COVID, so the virus obviously does survive high altitude. And you're right, the low humidity is a very important factor. Even we are probably, I can tell you a prediction now, as I did before, that ultraviolet will protect us. I can also tell you that the mucormycosis probably will be much lower here than at sea level or lowlands, because like in bread, when we leave our bread here at high altitude, it will take several days before the fungi grow, not like at sea level where it grows very fast. Here we can keep the bread very long. So it's definitely a factor. You're right, a factor. It's a multiple factor. You'll have to read our last paper that's about to be submitted, and Natalia is the principal author, and it touches many aspects.
So thank you very
because
much.
Because it is important, might be important for all audiences, because the air condition showed that it increases the infectivity to the virus, because no matter if in the house or in the car, as soon as you're using the air condition, it absorbs the water and lowers the humidity of the car or of the room. That causes the virus to be separated from each other, and with lower water content, it becomes more airborne and more infectivity can be seen. This is why in the very hot area, even in southern part of Iran, in the beginning of summer, while we were expecting to have low infectivity because of the higher UV, unfortunately, we found higher infectivity just because the people use more air condition and made the virus airborne and then became infected.
Right. So thank you. I think that now time has come to conclude. Professor Gustavo Zubieta Kelikapa, I think that no words of me. Actually, I cannot tell anything more than that. A lot of profuse thanks and gratitude to Professor Gustavo when I have actually shared that I like to contribute on behalf of my university to fitting tribute to Professor of Medicine and Vice Chancellor Dr. M.S. Biradar, who passed away on 12th May. So he immediately said, let us have something different. And we together, we made a plan, got all blessings and support from our principal, Dr. Arvind V. Patil, and Vice Chancellor in charge, Dr. R.S. Mudhol sir, and all my colleagues. And we get together and we made a plan. So thank you, Professor Gustavo, on behalf of the BL University to you personally here, because the vote of thanks will be given immediately after presidential remark, that is the last one, by Professor Dr. Natalia Zubieta, who is the legacy of Gustavo Zubieta Castillo, the father of Gustavo Zubieta Calica here. So she may skip the appreciating to her father. So I thought that it is my last opportunity of me to salute to Dr. Gustavo as a scientist, professor, my great friends, and a legendary figure himself, and great organizers, and a great human being, and bringing and following the legacy of science in a true spirit of ethics and this ones. And thank you, Dr. Hamid Mubashiri. It is always pleasure to see you and meet you always. So I now request Dr. Kalan Shettar, S.S. Kalan Shettar, to hand over the certificate of honors to legendary Professor Gustavo Zubieta. Anand, kindly. Dr. Anand, Mr. Anand is doing an extremely good job. It is now 10 past 15 in India time. Since whole day he is working and he's still there with the support of the chairman of IT, Dr. Deepak Chauhan. Both of them, we are proud of them, the IT department. Anand, please upload the certificate.
Sir, it's my honor to present the certificate of honor to Professor Dr. Gustavo Zubieta Calaha.
Thank you.
Thank you very much.
I don't see my certificate.
It's coming, sir. It's coming.
Yeah.
Okay.
Yeah.
Thank you. Yes,
Dr.
I see it now.
And Dr. Gustavo, I will send all certificate to you also along with others. So you can also from your side.
Thank you. Thank you. Very
Great
honored.
honor. So now I request Anand to give the certificate of recognition. I think I request Dr. Gustavo, you please hand over the certificate of recognition on behalf of BL University and IPPA Zubieta.
Yes, here you are.
Yeah.
Yes, Dr. Zakru, Kali and Shetar, here is, please handle it. Please take this.
Okay, yes.
You deserve it. Thank you very much.
Thank you very much. So I think now the time is over. So with the permission of the president, now the last part will be two. First is the presidential remark. After that, immediately the vote of thanks by Dr. Natalia Zubieta, the daughter of Dr. Gustavo Zubieta and legacy of Senior Zubieta. She is a medical doctor, MD in internal medicine, and a great scholar, researcher, enthusiastic, very young doctor as itself. And I had an opportunity to host her as a research trainee at my institution, like Nino did it in his laboratory in Washington. So I will now request the president of today's function, Dr. Arvind B. Patil, Dean of Faculty of Medicine, to take the mic and give his presidential remark. Over to President Dr. Arvind B. Patil.
Good evening and good afternoon to great scholars. At the outset, I'm thankful to Das sir organizing a wonderful memorial series on behalf of our university to befitting tribute to Dr. M.S. Biradar. I'm sure he would have enjoyed more than any one of us, because in all the time he was very much inclined towards research, particularly at molecular level. And today all my 4 guest lectures have delivered the contest what our Professor M.S. Biradar sir wanted. And I'm sure his dreams will be taken with the support of you, sir. I beg the support from all of you and connect us to the world from different, through your science, where our young scientists are also willing to work with you. I request all the 4 speakers, please do connect us with the research which you have said. So I'm very much thankful to Paulo, sir, who gave us a wonderful gist, but there is still a controversy in our own institution. There is a debate on intubation is to be delayed as much as possible, but sir throwed a new light of intubation should be as early as possible wherever indicated. Then we heard from our Kolar sir about the cardiology, the exercise and the hypoxic induced. Yes, that is going to be another area which we should always look upon and build the hypoxic states in many situations we come across in the future. Then as usual, our Nino sir, very humble and very informative scientist who gave us about the various aspects of the breathing thing contest. Then Gustav sir is always not a outsider to us. He's always a part of the university, physically as well as virtually. No functions happens on international function without Gustav sir. Sir, your connection with the global people and connecting our university, we are very much humbled. And I'm sure my young scientists are inspired by you. Only my request to you is, please do take our youngsters under your stride and guide them so that it will have a meaningful what Dr. M.S. Biradar had dreamt. And I'm sure Das sir is doing in that right way. And I'm very thankful to Das sir connecting such wonderful people. And I will not forget Hamid Musawi sir. Every time we are connected, he's always there and very active member. He never leaves any opportunity to question. By virtue of that, we learn. So we thank you, all of you. And I'm, sir, immensely thankful to you, sir, personally, for making me a president of this function. Thank you, one and all.
Thank you very much, President of today's function, Dr. Arvind B. Patil. I like to request that now the last part. So, with the permission of the President of today's functions, Dr. Arvind B. Patil, and I thank first to Dr. Chief guest of our function, Dr. R.S. Mudhol sir, the Honorable Vice Chancellor, and all of them, and deep contribution of all the faculty members, chairperson, and the today's visitors and the young people who ask the questions, doctors, that also need to be acknowledged. So before I hand over the mic to the last but not least, that is Dr. Natalia Zubieta Uriestos. Dr. Natalia, the young scientist from La Paz, Bolivia, internal medicine specialist. Dr. Natalia.
Greetings to everybody. Can you hear me well?
Yes, you're audible.
Perfect. Thank you very much. Thank you immensely for this opportunity to thank in behalf of everybody. From La Paz, Bolivia, as you can see, I have put a picture. We have a beautiful day with a lot of UV in the mountains. And from here in La Paz, Bolivia, in the south of the Americas and the American continent, we are connecting with people from India who are in Asia. We're connecting with people from Europe, such as the Honorable Paulo Pelosi, such as a wonderful František Kolar from Czech Republic. We are going to the northern part of the American continent with Jan Marino Ramirez. And this is all thanks to this wonderful human being that we will miss deeply, Professor Dr. M.S. Biradar. He was a wonderful human being. And he was a wonderful human being because he gathered a team with great vision, so hardworking, so humble, and yet so kind and dedicated to research, to education. That's why this was organized by his university, where under provision and all the support of Dr. Arvind Patil, who has always been so supportive and willing to make all these dreams come true, along with wonderful Professor Kusal Das, who has also been part of this team. And we have also gathered all these people, not only from every part of the world, because these are only a couple of people, but it's just to remind ourselves of the potential of our union. And COVID has been a wonderful opportunity, because thanks to it, we have been able to connect not only through hypoxia, but throughout the world, throughout different levels, from the high to the lower lands. And we are all learning this together. And so I just want to thank everybody for coming, for participating, and all the people who have been part of the session that we have repeatedly named. But I will once more, to make sure it's clear, thank you so much to all. First, Honorable Aravind Patil, who has made this possible, Chancellor of BLD University, also Mudghol, Dr. Mudghol, who has been part of this and has now taken this opportunity to be part of the group. Our wonderful speakers of these sessions, among them Dr. Paulo Pelosi from Italy, Dr. František Kolar from Czech Republic, Dr. Gian Marino Ramirez from the USA, my father, Gustavo Subieta Calleja. Thanks to him, I'm part of this as a high altitude researcher. It's an honor. Thank you for having me. And our chair guests, such as Honorable Dr. Kaliash Nasher Chetar, Basa Harav Badalal, Sanjeev Sajadar, and Dr. Vidya Patil. I apologize if I can't pronounce well the names, but I do my best and just take it with great heart. So thank you so much for everything. Thank you everybody for participating. We are greatly moved by this, and we're also hoping for better times together. Thank you. Have a wonderful day.
Thank you very much, Natalia, for excellent vote of thanks to all the people here. And now program is going to be closed. Before closing, I request Dr. Arvind Patil is here. Dr. Arvind? Yeah. So I just like to conclude it by just what these things that
Dr. Das?
Yeah, Dr. Mudal sir is there. Yeah, Chief Guest. Sir,
wonderful connectivity all over the world.
Sir,
And
you have one last
really congratulations to you. It is it is again befitting the arrangement for Professor M.S. Biradar. Hearty congratulations to you and the Gustavo. Both of you have done a wonderful. Dr. Biradar soul will be observing us. Thank you so much, and is a wonderful tribute to him. On behalf of the university, will continue his dreams of the connectivity all over the world with all our research and all your activities. Thank you so much.
Sir, thank you so much. Sir, you have the last one work to do it. That is, I request Anand, you are here.
Sir.
You please upload the certificate of recognition of IT department. Please upload. Sir, Honorable Vice Chancellor, sir, I request you to kindly hand over the certificate of recognition to IT department headed by Dr. Deepak Chauhan, Mr. Anand Patil and his team. They have done a great job, and we are thankful to him at the late night now in India, but they did it all. So, sir.
Yeah. It is my honor to hand over the certificate to the IT department, especially Dr. Deepak Chauhan and also Anand Patil. Wonderful team we have. On behalf of the university, it is my honor to hand over the certificate to them. Thank you.
Thank you, sir. Thanks so much.
Thank you very much, sir. And I think that it is the time to depart ourselves now. So all the guests, all the speakers, and the Honorable Chief Guest, President of the function, respected Professor B.G. Mulimani, sir, and all the participants here, that let us not conclude here. Let us start a new journey with the philosophy and idea and thoughts of Dr. M.S. Biradar, sir. a professor of medicine, a legendary medicine professor, and a great clinician, great teacher, and a great administrator. So thank you, all of you. Thank you. Goodbye, all of you. Take care.
Thank you. Bye-bye.
Bye-bye, Dr. Pelosi. Bye-bye.
Bye-bye.
Bye-bye, Dr. Gustavo. Professor Gustavo.
Thank you.
Natalia,
Goodbye.
Bye-bye.
Thank you for
Bye-bye.
everything.
Thank you very much. Thank you.
Bye-bye,
Thank you,
everybody,
everybody.
and have a nice time.
Thank you, Dr.
Thank
Hamid.
you.
Thank you, Professor Fantasy
Goodbye.
Koda, all I'm saying. So thank you, Professor Pelosi, all of you. Thank you very much. Thank you all. Bye-bye.